communication. If you look at all the corporate world, the communications are only for 5 minutes. Each speaker talks only for 5 minutes, and then there's a discussion, and then discussion comes with final conclusion and action. So this is how we should. This is what my vision for Federation is. The future vision is less talk and more action. That is an abbreviation of action, abbreviation of thought, because otherwise there is too much information. How do we reproduce it? How does one make 37,000 people reproduce the same action so that there will be a change in society? If it is a definitive action, then only there will be a change. Otherwise, there will be no change in society. So anyway, these are thoughts which are more larger and more holistic, and we have to change with the time. Our 15-minute talks have to be now finished talk. Only 5-minute talks should come in now, in the future. Anyway, thank you very much.
Thank you so much. Thank you so much, Dr. Rishikesh, for all those enlightening words. And we are so looking forward to your presidential year and looking towards a sea change in the attitude and the functioning of so many parts of FOGSI. Thank you so much for your words.
Thank you.
And we will surely take them forward. And now I have the proud privilege of introducing our guest of honor, Dr. Uday Thanawala sir. He is the chairperson ICOG. He is a private practitioner. He's a lecturer at KM Hospital. He is a skilled surgeon and a member of the New European Association. He has been the ex-vice president of FOGSI. He has hosted a number of, he performs a large number of gynecological surgeries and offers them laparoscopically too at his center. He has been invited as faculty to many national and international conferences and has contributed a number of chapters to many books. He has been the chairperson of Medical Disorders Pregnancy Committee of FOGSI 2006-2009 and has been the founder, secretary and president 2007-2009 of Navi Mumbai OBGYN Society. Sir, we would really like to hear you speak and bless this webinar.
Yeah, thank you so much, Charu. Thank you for having me here. I was here last Saturday also. Oh. And thank you, Sneha and Dr. Manisha for having me again over here. And it's very interesting, the concept which you've developed. In fact, as taking it forward, maybe we should really think about ICOG joining hands and having a proper module which we can run repeatedly over some weekends so that many more people can be reached out to. This is a fantastic thing what you've done as E-Conclave, and we have a lot to learn by the e-platform because ICOG has started a lot of weekend courses for gynecologists because we realize gynecologists who are practicing are generally free on the weekends, maybe Saturday afternoon, Sunday afternoon. And then that is the time when they can easily log in from the comfort of their homes and, upgrade their knowledge. So Sneha, let's think about having a module which we can do together and through ICOG so that more people, more FOGSI members can be reached. This is a fantastic initiative, wonderful lectures, wonderful program put together, and it takes a lot of hard work to put all this together. So congratulations on all this. Wish you all the best. Manisha, Sneha, Charulata. And I must also mention, I saw that film which you have made, Sneha. It's for that the awareness of breast cancer with breast cancer survivors. It's amazing. It's very good. Very well done. Very well made. And it really takes the message. So maybe we should even put it up on the website of FOGSI and
yes, we have actually. We have officially forwarded, yes.
Very good. Very good. So it's something which should reach many, many more people. So yes. Congratulations for that and wish you all the best for the future.
Thank you so much.
Thank you, Dr. Thanawala. And we really look forward to working with ICOG more and more. And maybe we could have, a breast module also ready over the next few years with Sneha at...
no, next, not
next month. Charu, not next few years. We have it ready.
Yes, so
yes,
I will work on that. Get to me. You and Charu be in charge and we will take it forward. Thank you.
Yes.
Thank you.
Thank you so much.
And now it is with great admiration and appreciation that I welcome and introduce Dr. Sneha Bhuyar, Chairperson, Breast Committee, FOGSI. Well, she's not only a friend, she's also a philosopher and guide. And whatever I am today is thanks to you, Dr. Sneha. And so many others like me will also voice the same opinion, that you always lend a helping hand to anybody who wishes to do well and who wishes to serve the society through FOGSI. Coming from a town like Yavatmal, she has gone a long way. She has got 34 years of experience in obstetrics, in infertility, laparoscopy. Today, she's also the ICOG Governing Council member. She has won a large number of awards and recognition for her immense work.
Okay. Thank you, Charu. Thank you so much for that generous introduction, I would say. A very good afternoon to everybody, especially respected Dr. Rishikesh Pai, Dr. Nandita Parshidkar, Dr. Uday Thanawala sir, and all the respected dignitaries who are from the FOGSI, Association of Breast Surgeons of India, and ICOG, and all the other organizations, including the NGO ICanCaRe. So at the outset, I would just like to share with you, as breast committee chairperson, basically I'm a hardcore obstetrician, but since I have taken this breast committee as chairperson, we are working for 3 reasons mainly: breastfeeding promotion, benign breast diseases, and the awareness, screening, and early detection of breast cancer. And for this, we are sensitizing the FOGSians in the form of, lots of CMEs, newsletters, and the educational booklets and books. At the same time, we are training the paramedics, and we are making general public awareness through all those competitions, posters, slogans. We are doing awareness through informative articles and such short films and videos as well. So coming to this program, yes, Dr. Manisha approached to me through ICanCaRe, and she invited breast committee to join hands with this. But I just thought, on a smaller scale, rather than doing this program on a smaller scale, we should join hands with FOGSI and ICOG so that maximum FOGSians can be reached, and this program can be spread across the country. As you all will agree to me that yes, early detection saves lives. That's the main thing behind breast cancer. Western countries, mainly, they have lots of cases of breast cancer, but the mortality is only 2 to 3%. On the other hand, we have lesser number of breast cancer cases, but the mortality is 60%. And the only reason behind this is early detection. We lack awareness and screening programs, which are the organized screening programs. And I hope we can reach to the government also through this, through our own parent organization, FOGSI, and we reach this message to the government of India as well, and we can work on it. But yes, by the time, what advice we are giving to the FOGSians, that every FOGSian is privileged because the women come to us for whatever their problems, and we have to make it a point to examine their breast and find any abnormality, if at all, get investigated. If no abnormality, teach them self-breast examination, make them breast aware so that they can come to you at the earliest, and we can, detect earliest, and we can save their lives and save them from all the complications which are associated. So with this, I wish all the best to this program, and I thank personally all the guests and respected dignitaries for gracing the occasion. Thank you so much, Uday sir, especially, and Nandita madam and Rishikesh sir. Thank you, sir.
Thank you.
Thank you very much, Dr. Sneha, for your message. And now I would like to welcome Dr. Manisha Pandey madam, Associate Director, ICanCaRe Women's Health Initiative, who's a senior consultant in OBGYN. And I would like to thank her from the bottom of my heart for having given me this opportunity, along with her entire organization. And I would request her to propose the vote of thanks. Over to you.
Thank you, Dr. Charu. Namaskar and Shubh Navratri to all the dignitaries and all the participants. It is my proud privilege to present the vote of thanks on this day. 2 of the iconic leaders of FOGSI are here to bless this International E-Conclave on breast diseases. It is a sangam of gynecologists, breast surgeons, and oncologists. I'm awestruck to have the mega stars of FOGSI here. Thanks to you, Dr. Sneha ma'am, once again, most respected Dr. H.D. Pai, President-elect FOGSI, and the dynamic past President FOGSI, Dr. Nandita Palshetkar ma'am, who had catapulted FOGSI to to be reckoned as a mammoth organization across the country. Thank you. Dr. H.D. Pai, sir, you have been, sir is here. I hope, sir, you have been a role model. Your zeal, enthusiasm, innovative working style is exemplary and contagious. And then your down-to-earth connect with one and all makes you so special. Thanking you from the bottom of my heart. And Dr. Nandita ma'am, please accept our heartfelt gratitude. Ma'am was extremely busy, and yet ma'am has found time to bless us with her encouraging presence. Again, I presume the flight is on, so ma'am is not available, but it's really great to have Dr. Nandita ma'am sharing her valuable wisdom with us. It means so much to us. I'm immensely grateful to our guest of honor, Dr. Uday Thanawala, Chairperson ICOG, for his kind and solid support to our endeavor of bringing breast awareness to women in each nook and corner of our country by sensitizing the gynecologist, the 3-tier program of the breast committee. Thank you so much, sir, for enabling us to enlighten the gynecologists and all the female doctors who are usually the first point of contact of breast cancer patients. Sir, you have not only encouraged us in organizing this program, but you have granted us ICOG credit points to motivate gynecologists to attend this program. I can't thank you enough. Thank you so much, sir. And again, it's my honor to share with you, Sir Dr. Uday, and all the dignitaries that online certificate course in breast awareness for doctors as well as for other healthcare workers has been approved by Gujarat University. ICOG is also planning, and as sir you said, together we can and we shall do it. We have to nail this, we have to rein in this menace of breast cancer, and together we'll do it. Thank you so much, sir, for being here. And then I have no words to thank enough Dr. Sneha Bhuyar ma'am, Chairperson Breast Committee FOGSI. I fully resonate with Dr. Charu's sentiments. Like a mentor, you have been supporting our campaign all through, guiding me personally, hand-holding me, and we have such a stellar FOGSI leadership with us. Thanks to you, ma'am. We couldn't have done it without you. Your hard work, sincerity, and loving support in organizing this collaborative event is just awesome. Thank you so much, ma'am. Dr. Pavan Gupta, the driving force behind ICanCaRe, and Dr. Meenu Walia, the chairperson of the conclave, the person who conceptualized this. A big thank you for this learning opportunity for all the gynecologists. I do believe, as madam said, a hardcore gynecologist, and so I am really enamored myself with this program. Profuse thanks to our dazzling MOC, Dr. Charu, for seamlessly coordinating the entire function at such a short notice. You took all the burden off our shoulders. Thank you so much for being here. Thank you for your motivation. Thank you, Team ICanCaRe, Dr. Reena Kumar, Mr. Risha, Ms. Shruti, and all the others who have worked tirelessly to put together this program. I heartily thank our esteemed faculty, the learned panelists and moderators who have spared time to be here. Last but not the least, I thank all the doctors from FOGSI Society, breast surgeons, and others attendees for their encouraging presence. To quote Brian Hubbard, the capacity to learn is a gift. The ability to learn is a skill. And the willingness to learn is a choice. So on a weekend, so many people here together, that is a choice, our choice. Let the lamp of learning always be alight. Thank you so much. Dhanyavad. So we proceed. Thank you so much, everyone. We are really blessed to have you here. now we proceed to the scientific sessions of the day. Handing over to you, Ms. Shruti.
Thank you so much, ma'am. I think that was totally wonderful. And we had such beautiful stalwarts and lead members on the forum. I feel totally privileged to have met them and to have learned so much of them. And to, that energy, that passion, that enthusiasm really create a difference in controlling the breast diseases across the country. It's just contagious. I feel so energetic and motivated. And I'm sure that together we're really going to make a lot of difference in the coming months when we work together, when we really bring out the cream from the entire medical professionals who can really bring out this change and help curb the menace of breast diseases in the country. With this, now we move ahead towards our scientific session, and I take this great honor to invite our own dear Dr. Meenu Walia ma'am again on the forum to please declare the sessions open, the scientific sessions open for the day.
So thanks once again, Shruti, and I will not stand for long. Between now the academic fiesta, the real thing, why we have all gathered today. And let's start with the scientific session. And I hope at the end of the day, we all gain from each other. We are all wiser. And as Manisha has very beautifully put in, to seek knowledge and to be there. I mean, earning to seek knowledge, willing to seek knowledge is also a very important thing. And the three most important things we were discussing with our gynecological friends, and we found that majority of the patients that really come to the OPD, is generally the most important things they address, they want their doctor, their gynecologist to address is mastalgias, nipple discharges, breast changes, and breast lumps. So we have tried to cover these sessions today by the stalwarts in the field, and we have
Dr. Sandeep.
So Shruti, you are on a mute. Yeah. So we have the stalwarts in the field, and I will request Shruti to invite them, and let us now start this academic fiesta.
Thank you so much, ma'am. I think we're all excited. Our viewers have also joined us on social media platform on YouTube and Facebook, and they're very eager. They're messaging us when is the scientific session starting. So with this, now we move ahead to the first scientific session. Dr. Sandeep has a little technical problems, and he'll just try to join us. So in the meantime, I'll take this privilege to invite Dr. Professor V. Sinu, who is Professor of Surgical Disciplines at All India Institute of Medical Sciences, New Delhi. Sir is an ardent and a very passionate breast cancer surgeon, and we are totally privileged that we have him here on this forum to enlighten us about the assessment of the nipple discharge. So I'll request sir to kindly please take the dais and talk about the assessment of the nipple discharge. Over to you, sir. Sir, you're muted.
I just want to know whether I am speaking or Dr. Sandeep is speaking first.
Sir, you will be speaking first because Dr. Sandeep is having some technical problems to join us. That's why, sir, I've invited you first.
Okay, thank you. So let me share the screen then.
Sure, sir.
Yeah. Can you hear me?
Yes, sir, perfectly.
Yeah. So basically, the task which has been given to me is to discuss about nipple discharge. And when you see about, say, 100 patients in an outpatient on a day, then you find that, as Professor Dr. Meenu Walia was telling, majority of them present with something called as mastalgia, which will be about 50 to 60%. And then there will be some who will be presenting with lump in the breast, which will be about 30%. And about 10% of the patients who present to any OPD is surgical OPD is the patient who has nipple discharge. Now, by nipple discharge, what you mean is that a spontaneous efflux of fluid from the nipple, apart from the physiological function of puerperium and lactation. This is the definition which, as scientists or researchers or surgeons, we follow. But for a patient, any discharge which comes from the nipple, whether it is spontaneous or pressure, the patient considers it as nipple discharge. Now, from the point of view of management, it is very important to know whether this nipple discharge is from one duct or multiple ducts, whether it is one breast or bilateral, whether it is spontaneous or comes only on manual compression, and the nature of the discharge, whether it is sanguineous, serous, or brown colored, and other thing is persistent. So we consider a nipple discharge to be significant when it is unilateral, single duct, spontaneous, serous or sanguineous, and persistent. This is the nipple discharge which we are concerned. And why we are concerned is that in such patients, the risk of malignancy is about 10% if it is women between the age of 40 and 60 years, and about 30% in women above the age of 60 years. This is the reason why we consider this nipple discharge as significant. Now, when we classify the nipple discharge after we examine, then we consider it as physiological galactorrhea, which is the expression of the milk. And the cause is basically the stimulation of the breast. And this is very physiological during pregnancy, but in the extremes of reproductive age, sometimes there can be physiological galactorrhea. And there is something called a secondary galactorrhea, which the gynecologists know more than us. It is probably related to drugs, a tumor in the pituitary gland, an ectopic prolactin secretion, hyperthyroidism, chronic renal failure, and others. So these are not the discharges about which we are worried. And so also a discharge which is colored or opalescent. When we mean opalescent, that means that it is opaque. When we mean colored, what happens is that the nipple discharge it is secreted mostly in the terminal duct lobular units. So by the time it comes to the surface, it undergoes various changes. Suppose there has been a blood. Then by the time it comes to the surface, it undergoes degradation to heme and then bilirubin and biliverdin. So you can have some greenish discharge or yellowish discharge. So this sort of discharge is commonly seen in women who have periductal mastitis, ductectasia, or in some patients who have breast cysts. Now, the discharge about which we are worried are not these three. What we are worried is about a watery or a serous discharge, or a serous sanguineous or a frank bloody discharge. Why we are worried is because this sort of a discharge is always associated with hyperplastic lesions in the lactiferous ducts. And this could be either a papilloma, a ductal hyperplasia, a ductal carcinoma in situ, ductectasia, and sometimes malignancy. Rarely in pregnancy also you can have some serosanguineous and bloody discharge. But this discharge we are worried when a patient presents to us. Now these are the discharges we are talking about. This discharge, as you can see here, it is a bloody discharge which is coming from a single duct. This discharge we will not be very worried because this is from multiple ducts and this is white and cheesy in color. And this is a serous discharge which you can see more clearly in this picture center. This watery discharge, again, this discharge worries us. Whereas this discharge, which is yellowish in color, again from multiple ducts, this does not worry us much. So this is the importance of knowing the color and the consistency of the discharge, because that puts the surgeon in the process or in the path of making a diagnosis. Now, what do we do when a patient presents with nipple discharge? Like as in any other breast problems, triple assessment is the cornerstone of evaluation of nipple discharge. By triple assessment, what we mean is history and clinical examination, then radiology in the form of imaging, either mammogram or an ultrasound, and very rarely needed an MRI, but most of this can be sorted out by getting a mammogram done or an ultrasound. Mammogram in women above the age of 40 years and ultrasound in women less than 40 years. Cytology, initially there was a lot of enthusiasm to do cytology, but nowadays the smear cytology of the nipple discharge is more and more being considered as not useful or ineffective, because the sensitivity of picking up a malignancy is just about 40%. And this discharge can be more useful if somebody can go into the duct, suction the fluid which is available so that you can have larger quantity, or lavage and take out so that you can have cells which the pathologist can have a look under the microscope. And people have found that when you do a suction lavage and collect the fluid, and if you do a fish technique, then there is 100% specificity for malignancy. However, these are uncommon and not routinely used in clinical practice. So is ductography. Ductography is again a high positive predictive value but low sensitivity, and it is painful. Like this picture shows a ductogram, and in the current day and age, does not give much information. So now it is more or less relegated to scientific discussions. Ductoscopy is a very new procedure, interesting procedure, in that scope, a fiber optic scope, which is less than 5 mm, is used to go into the duct. The duct is gradually dilated. You go into the duct and you can easily visualize a papilloma or something, and if needed, you can take a biopsy. And occult blood testing is another thing which people talk about, but this is of not much relevance. So it boils down to that in any case of nipple discharge, again, it is a triple assessment, which is the cornerstone of evaluation. By triple assessment, I mean history and clinical examination, imaging in the form of ultrasound in women less than 40 years, and mammogram in women more than 40 years. And then you do a cytology or a histopathology if you find a lesion. Now coming to the management, like if it is a galactoria, and as I said, this we do not deal much, the gynecologists deal with it more. And if you know that there is a mechanical cause, you can eliminate the mechanical cause. If somebody is on a medication, it can be stopped, then you can stop it. You can measure the prolactin to see whether there is anything in the pituitary. And more often it settles down on its own. And what patient needs is just a good reassurance. Then the colored fluid, and again I said colored opalescent fluid is usually seen in benign breast conditions such as periductal mastitis and ductectasia. And in these also, reassurance will help the patient because this is usually seen in the perimenopausal women. And once they attain menopause, it gradually becomes all right. But again, it is important that when a woman presents to you with this, take it as an opportunity and do opportunistic screening of these patients to rule out malignancies. However, if a woman finds that the discharge is very profuse, socially embarrassing, or if a patient is very worried about why the discharge is coming, they can do something called as a major duct excision. I will not go into the details. What we do is we give a periareolar incision and we deepen it and we excise the ducts up to the terminal ducts or to a distance of about 2.5 to 5 centimeters. All the ducts are excised. So this is called as major duct excision. This is not recommended in women who are about to become pregnant and they want to lactate because lactation cannot happen. So this is recommended more in perimenopausal women who have finished their family. And coming to the most important one is the bloody related discharge, a serous discharge or a watery discharge. And as I said, if ultrasound shows that it is located to one duct, then either in the current day and age, you can do a biopsy of that, localize it, or better is to do a microdocectomy if one duct is involved in women less than 35 years. You give a periareolar incision, you can dilate the duct, and then you visualize the duct, you can inject a dye, visualize the duct and excise it to the point that it is ending into smaller ductules. So this is a classical technique which is used. However, if it is not confined to one duct, and then you can do something called as a major duct excision, which is removal of about 5 centimeters of the all the lactiferous ducts, because most of the primary and the secondary lactiferous ducts end to a distance of 5 centimeters. So if you remove this, most of the patients respond to treatment. Of late, the radiologists have been making efforts in doing this procedure using an ultrasound, under ultrasound guidance using a mammotome. So to put it shortly, whenever a patient presents with nipple discharge, one needs to know whether it is a significant discharge or not a significant discharge. You say discharge is significant when it is unilateral, single duct, serous or bloody, then it is considered as a significant discharge. These patients have to undergo an ultrasound if they are less than 40 years. And an ultrasound will usually show you a dilated duct. And if it's a single duct, you do a microdocectomy. And once you do a triple assessment, you will know if a patient has malignancy. Then the malignancy has to be confirmed and staged and treated according to the stage in which the malignancy falls. Thank you. Thank you, Dr. Shruti.
Thank you so much. I think that was so lucid, so nicely, very well explained. I'm sure that a lot of questions would have been answered by our audiences. I'll just request if all the participants who are here with us, If there are any questions, please put it down on the chat box. We're going to take it up towards the end of the scientific sessions in a 10 minutes discussion. I'll also request all our viewers on the social media platform that please post your questions and we will forward it to Sir for answering. Thank you so much, sir. I think that was very beautifully and wonderfully explained. We now move on to our next topic, the next scientific session on breast infection, the granulomatous breast diseases. And for this, I take this privilege to invite a very prolific breast surgeon from the UK. He is Dr. Iqbal Kasana, currently consultant breast oncoplastic reconstructive and breast cosmetic surgery from Walsall Manor Hospital at West Midlands, UK. Sir is a leading clinician for breast oncoplastic surgery at the hospital and has special interest in the breast reconstruction with implants and cosmetic breast surgery. He is also the member of Association of Breast Surgery and Royal College of Surgeons of Edinburgh. With this, I invite Sir to kindly present his.
Hello, can you hear me?
Yes, sir, we can hear you, but there's, I think, a slight disturbance on the video.
It shouldn't be actually, be all right.
Okay.
Yeah. Hi, good afternoon, everyone. Thanks for asking me to give a talk on this topic. Thank you, Dr. Sinu. Dr. Sinu is the person I learned everything from. I was his senior resident quite a while ago. Now, coming to the topic, thanks to Dr. Geeta Shetty and all other organizers. I was talking to Dr. Shetty a couple of days ago, and she told me to keep the talk to the practical aspects rather than the more theory and deep scientific aspects of the topic. So anyway, we move on. Infections of the breast. This is actually a very nice topic to discuss. I was wondering, we go to conferences, CMEs, and we hardly ever see this topic being discussed. It's quite a neglected topic. From patient's point of view, the symptoms of breast infections, whatever types of breast infections, are extremely distressing, way more than the symptoms patient experience from the breast cancer, though the breast cancer has its bad implications, but these breast infections cause a lot of suffering. And what I've seen is even in the specialist hands, a lot of times is mismanaged because the topic itself is taken lightly, it's not addressed properly, and it's quite a neglected area. Breast infections are common in reproductive age. There's a lot of emphasis on given laid on the breast cancer associated with breast infection, but in reality, that's relatively uncommon. But we must not forget inflammatory breast cancer, which can present as breast symptoms and signs similar to breast infection. So one must be wary of when you're dealing with breast infection-like picture. So the wide spectrum of breast infections which we see in day-to-day life. This is the list of what we see. Mastitis neonatorum is seen in newborn. You must be seeing them a lot of time, a lot of gynecologists on this forum. And then lactational mastitis or abscess, peritectal mastitis, then general non-lactational abscesses, idiopathic granulomatous mastitis, tuberculosis, and then few relatively uncommon, which I'm not going to go into more details after this, foreign body, because foreign body granulomas and infections, because we see the incidences of ladies injecting things to get their breast volume up. Skin infections are similar to skin infections anywhere in the body. Infected sebaceous cyst and hidradenitis suppurativa can affect the breast, and the presentation and the management is very similar to these infections anywhere else in the body. Now we take these topics one by one and go through these. Mastitis neonatorum is the infection of newborn breast wounds. I haven't seen personally many cases, and I guess the gynecologists and pediatricians manage them well. And it's a simple inflammation or infection, and the usual causative organism is Staph aureus, sometimes E. coli. And treatment is simply antibiotics. Antibiotic of choice is flucloxacillin. Rarely, if it doesn't settle down and turns into abscess, then the baby will need ultrasound guided aspiration with a thickened gauge needle, or again, very rarely, you need a drainage with a stab incision. In this case, the incision should be kept as far from the nipple as peripherally as possible to avoid damaging the breast mount, which will have future implications. So we're not going to go into further details of this. The next one, the commonest one, which you would be seeing in your practice is lactational mastitis. So this is basically a common infection in breastfeeding ladies, mostly seen in early postpartum period. And the main cause of this is crack in the nipple, crack in the skin, which leads to infection. The causative organisms are usually Staphylococcus or Streptococcus. How the ladies present is acutely painful, either it's a whole breast or part of the breast, with the constitutional symptoms like fever and sweating and generally unwell. How do we manage when we see patient who is lactating with this type of acutely inflamed breast? The first thing we do is do an ultrasound scan to rule out an abscess. So if it's just a cellulitis and no abscess, treatment is simply antibiotics covering the staph and strepto. Flucloxacillin is a choice what we use in our units. If the ultrasound scan shows an abscess formation, then we need to drain it. Our method of draining is ultrasound guided drainage with a thicker needle. 14 gauge is what I normally prefer. I usually use a Venflon. Use a local anesthetic and inject the local anesthetic, aspirate, inject, so kind of give a wash through a needle. And we repeat the scan at 48 hours, and the process usually need to be repeated to get over it. Now, as far as the lactation goes, we advise ladies to continue expressing the milk from the affected side. They can continue to breastfeed from the other side. Very rarely I see cases where the infection comes back within days or weeks after treating and keeps happening again and again. In such a relentless infection, we advise ladies to stop breastfeeding, and we suppress breastfeeding by giving them cabergoline. Short course, 4 doses of cabergoline will suppress the lactation completely. I'm sure you'll be more familiar with this than we are. When do we do surgery? There are occasions when aspiration fails, or when the overlying skin is necrotic, we have to debride it. Sometimes a large painful abscess, patient won't allow you to touch, forget about doing in the local anesthetic. And sometimes the abscess has already opened up, but it still hasn't fully drained, and there's a lot of necrotic tissue which need to be debrided. And then we, in that case, we do under general anesthetic, drain it, debride the necrotic tissue, and leave the wound to heal by secondary intention. Now, the other form of infection is periductal mastitis, which a lot of times turns into mammary duct fistula later on. Very similar to perianal sepsis or fistula in ano, managed by our colorectal surgeon colleagues. This typically affects young smokers who, it normally affects the central breast, nipple areola region. So ladies present with acutely painful, tender lump in and around the nipple area. A lot of times it'll show the nipple is inverted. Some ladies present with discharge, which could be purulent, as the the pus could be draining through the milk ducts. The fundamental difference from lactational mastitis is this is the organisms. So this is the difference. In fact, if someone wants to remember one point, and this is the point to remember the difference between lactating mastitis and this I call it smoker's mastitis, is the causative organism. In this is the staph, anaerobes, gram-negative bacteroids. So that makes the choice of antibiotics differ from lactational mastitis. Lactational mastitis is a staph and strepto we treat with moxicilline or flucloxacillin. Here we need to use anaerobe and gram-negative cover. How we manage? We again do the ultrasound scan. If it's cellulitis only, no abscess, treat with antibiotics. In this case, antibiotic of choice is comoxiclav or clindamycin, or you can use amoxicillin plus metronidazole. If the ultrasound scan shows an abscess, we do ultrasound guided drainage, again with the thick Venflon. The key is I do myself in clinic. I do not try to drain through the area where the abscesses are red, because extremely painful and local anesthetic doesn't work. I try to go through a remote location, slightly away from the abscess, which is virgin area, which local anesthetic works well. From there, the needle is from where the needle is put in, and go deep, reach the abscess cavity and drain it. Again, when do we do surgery? Indications are same. If the aspiration fails, overlying skin is necrotic, large painful abscess where patient won't allow you, or the abscess is already open up. The main and probably the only causative factor is the smoking, and the patients must be advised to stop smoking, otherwise keep happening. Antibiotics, I already said, these are the choice of antibiotics, different from lactational mastitis, which can be treated with just a gram-positive coverage. Here we need more broad spectrum coverage. A lot of times after the abscess is resolved either with the surgery or with aspiration or spontaneously, it leads to mammary duct fistula. So I hope you can see, this picture is not clear, where the mammary duct fistula tract develops, and it leads to recurrent abscess and recurrent drainage, and patients have symptoms every few weeks, which are very distressing for the patient. Unfortunately, mammary duct fistula is not easy to manage, and invariably we need to do a surgery, and the surgery will involve excision of the fistulous tract. If the symptoms are not resolving, and we need to do ultrasound scan to see if there is any solid mass, and image guided biopsy is required to rule out malignancy. Ladies who are in 40+ age, they will need completion mammogram to rule out underlying malignancy. As I earlier said, any inflammatory condition, we must keep in mind inflammatory breast cancer. Anything which is not healing, which is not going as per the expected course of infection, should be biopsy to rule out malignancy. Peripheral non-lactational abscesses are like abscesses anywhere else in the body. They're less common, but happen in ladies who are immunocompromised or with diabetes, steroid treatments, or sometimes trauma. Treatment is antibiotics, or if there is an abscess, aspiration. Surgery rarely required. Principle the same: incision and drainage and debridement of any necrotic tissue. Now, idiopathic granulomatous mastitis, very common, very interesting one. It's an inflammatory condition of unknown etiology. In UK, seen in ladies from Indian subcontinent and African origin. Normally seen in childbearing age. Average age of presentation is about early 30s. Ladies would have recent history of breastfeeding. The cause is not known, how and why it happens in ladies who just finished breastfeeding. Presentation can be tricky. It could present as a suspicious mass with or without a redness. Suspicious means suspicious about breast cancer. And other times it could present as abscess, which is not responding to antibiotics or aspiration or drainage. You drain it, you treat it, it doesn't respond to antibiotics, recurrence rate is high, and the new areas keep appearing. In other words, it's a relentless infection, which we find it very difficult to treat. Management, conservative management, if the patient present as a lump, which we have assessed with the triple assessment, biopsy, and it proves granulomatous mastitis, but patient is asymptomatic. We don't need to treat it. We leave it alone. Good chance symptoms will settle, but if not, patient becomes symptomatic, then we have to treat it. How do we treat it? The simple aspiration, and if required, if say abscess, drainage will provide short relief. But the relief will be short and the symptoms will come back soon, or another abscess. If we see any mass, if we see anything unusual, so different from an abscess, we normally do a biopsy, which will classically show non-caseating granulomas, which are diagnostic of granulomatous mastitis. Treatment, we try to drain with the needle and do the medical management. Medical management is basically responds dramatically to steroids. A lot of my colleagues use very high dose prednisolone. I use low dose steroids on a couple of patients because they have other medical problems for which I could use. So I use 20 milligram daily, but some daily. The next bit is tuberculosis. We don't see that. I was a resident doctor in Delhi. I used to
I think network is lost, I think.
Yeah, Dr. Iqbal, I think we lost you. We're not able to hear you.
Yeah, I can hear you, but there's a problem with the video.
Yes, there's a slight problem, and also we can't see your deck right now.
What you can do is, Iqbal, you can stop the video and just do the presentation. Sometimes because of the network, it might take a quite
We
a
okay?
long
We
time.
okay? Geeta, I think we're back.
Yeah, it is better. It is better.
Yeah,
Continue, Iqbal.
Yeah, let me see. Okay, that's fine. So tuberculosis, they normally present at older age than the other infections, like 50 plus, more likely to fall in that group. And then from the endemic areas like India, Africa, those sort of countries, we hardly see. I only seen like 2 or 3 cases in the last 3-4 years. They're more likely to present with axillary lymphadenopathy or a cold abscess, which we all familiar with, abscess without any much of signs, or sometimes multiple sinuses. Half of these patients will have history of pulmonary tuberculosis in preceding years. Typically, again, doesn't respond to antibiotics. We do is aspirate. If suspected, we send for Zn-stain and culture. Biopsy, if we have something to biopsy, any solid area to biopsy, shows caseating granulomas, which are diagnostic of tuberculosis in the background of the relevant history. Treatment, again, is drainage of sepsis and anti-tubercular therapy. We send to our physician colleagues for the start of anti-tubercular treatment. Other skin infections, like we already said, the sebaceous cyst, skin infection, hidradenitis, very similar we see to what we see elsewhere in the body. So I'm not going to go into the details. I'd just like to summarize how we deal with the patient who present with the breast sepsis or infection, inflammation. History examination as standard, we do an ultrasound scan and aspirate under local anesthetic and send for culture and sensitivity. If suspecting tuberculosis, can send for ZN stain and tuberculosis culture as well. If we see a solid mass, we take a biopsy and start patient on antibiotics, as we discussed in previous slides. Incision drainage is indicated as we discussed, especially if the aspiration fails. Those who are not responding to antibiotics and aspiration, we biopsy under ultrasound guidance to rule out inflammatory breast cancer, and of course the other conditions, benign condition like granulomatous mastitis, tuberculosis. Ladies who are above 40, once their symptoms settle down, the pain and tenderness settle down, we always do a mammogram just to rule out underlying cancer. Mammary duct fistula, if they, for periductal mastitis, if it turns into fistula, we ask them to stop antibiotics, which is the causative factor, and invariably they need surgery to excise the fistula tract. Thank you very much.
Thank you so much, Dr. Iqbal. I think that was really a very good and comprehensive talk. I'm sure a lot of our audience would have had a great understanding about the subject matter, and there were a few discussions and questions also. But request if you would like to answer those questions on the chat box. Next, I would like to invite Dr. Somsekhar SP. He is currently the president of Association of Breast Surgeons of India. Sir is going to talk about approach to breast lump and triple assessment. He is currently the chairman and HOD of surgical oncology at MHEPL, consultant of surgical and gynec onco and robotic surgeon, HIPEC super specialist from Manipal Comprehensive Cancer Center. He has received the Times Healthcare Achievers Award in the field of oncology in 2019. He's also the recipient of Millennium Gold Medal Award for his work in sentinel lymph node. He's editor and author of various textbooks. He's contributed several chapters to various international and national textbooks in oncology, and has more than 300 national and international publications to his name. With this, I invite Dr. Somsekhar sir to kindly present his talk.
Thank you very much. I thank you, Shruti, and also Pawan and ICanCaRe Foundation for this particular initiative we have taken. And on behalf of ABSI, Association of Breast Surgeons of India, and as its president, it's pleasure and honor to be associated. I know I am aware that this particular CME, even though there are oncologists, breast surgeon specialists logged in and are a part of it, by and large, it is for gynecologists and also predominantly to general surgeons. So I've kept my talk basic for them. And I bring warm regards from ABSI, Association of Breast Surgeons of India, as its president, the theme of which is the voice for breast surgeons. And you know that it is established more than 5-6 years, and we have robust 1,200 people. And I also welcome you all to Kolkata in November for our on-site ABCCon. And there are about 10 Indo-UK travel fellowships and national fellowships, which is available for students. More than 100 free original papers normally are presented in this. I work in Manipal Comprehensive Cancer Center. You know, I'm a professor and head of chair of surgical onco and breast unit. We have a robust breast surgery fellowship, which is also recognized by STP, and most of my fellows after completing get placed in UK as a breast surgeons. So the message is, why should we not ignore any lump in the breast and not presume that they are benign or cancer? In India, what has changed is, we have a breast cancer which is a decade early. So which is something very important to understand. We are in a place where it is at least 1 decade early. There are 3 very unique things which happens in India. Number 1, India is the house for largest young women with breast cancer. A decade early. We have less hormone receptor positive disease. We have more HER2 positive disease. That's one of the reasons screening by memo alone not very effective in India. The ratio to radiographer who can report a qualified breast mammogram to number of patients and mass screening very inferior. And that's one of the reasons the RCT in India propagate clinical breast examinations. And most of our patients have high grade tumors, more than 60%. So this is something we must keep in mind before we go in and plan anything else. Third thing, we are all aware the stage at which a lady comes to you determines the overall outcome. So even though it is genomic analysis at this moment, luminal A, B, or TNBC, or we have basal like whatever, ultimately stage number 1, tumor size, lymph node, and then the receptor state HER2/neu varies. So look at it. Breast cancer is one of the few cancer where we say 10-year, 20-year survival cure. Unlike 5-year in other cancer that go on to show how good this is if we intervene early. Also, we all know that if you have a triple negative lady, 5-year, if she don't recur, we can almost call it a cure, unlikely recurrence after 5 years. If you have a luminal A, which is a HR positive, HER2 negative, late recurrence at 7 to 10 years are known. That's why cure term is not used until you cross 12 years. That's why one of the reasons extended hormone therapy is advocated. But the sad part, even though we are the second largest population in the world, 1.2 to 3 billion, breast cancer is rampant in Western world. Incidence highest come from Western world. But the sad part is we are not the number 1 feeder to the incidence, but 50% of death come from India. Very sad. Means what? In Western world, 95% of the women across the group is alive at 5. In India, 1 in 2 women at entire group is dead. 50% mortality across all the group, leave stage 1, 2, across all the incidents as per the National Cancer Registry. So this is very sad. We are number 1 in mortality. That shows healthcare, what we have to do. That's why ABSA, Association of Breast Surgeons, was formed to change the surgeon, standardize the care, bring our Indian guideline, Indian solution for Indian problem, make in India solutions, also to make our women aware to have a opportunity screening or some other form. How is Indian breast cancer again different than others? We are 1 decade early. We are detected late. 2/3 of our patients are LABC. Our 5-year survival, 50% only, unlike more than 95% in the Western population. Annual incidence in other places in the world is plateauing, but in India it is rising, very dangerous. We have adapted Western culture and already mortality is 50% and our incidence is increasing, and percentage of screened women in India is less than 1% to 90. These are very important statistics which I've picked up from public-based cancer registry in India and National Cancer Registry, which all of us has to work. Second thing, radiologists abroad who can interpret a breast imaging, look at it, in India, we don't even have 10,000 per people, 1 person, which is very sad in our country. So women don't do breast self-examination in our country. Clinical breast examination is a rare thing. Screening very difficult with mammography. That's why all gynecologists or anybody whom patients meet should understand. There is enough data which shows simple, if a lady does a breast self-examination, 18.8% mortality can come down. If it is added with a clinical breast examination, as per the randomized control trial published from Tata Group done in Maharashtra, 24.4% mortality can be reduced. Never overlook this. A woman knows her breast the best. Empower her to look, feel, and identify her breast. Most of the healthcare workers doesn't know. In a premenopausal woman, 5th day after period, she must perform breast self-examination. A postmenopausal lady where there are no periods, I always tell her, what is your birthday? Say 5th of so month and year. 5th, you remember. If your birthday is like 24th of November, 24th. So every day on your birthday, you do breast self-examination. And a woman who does breast self-examination, inframammary fold, axillary tail is the 2 places where they miss the cancer. Specially educate them to look at it as a healthcare provider. Clinical breast examination can be by any doctor or a trained healthcare professional. Should be done annually above 40. Or if you have a high risk woman like hereditary breast cancer, you should do more frequently. So it should be done in various positions. There are some myths. Even a good healthcare worker, good general surgeon, good breast, physician may not do this. There are something which are not done. You should not pinch with 2 fingers. You should divide the breast into 6 quadrants. Use a flat pad and do a circular movements. Palpate. Remember, breast also runs from axilla straight line to mid axillary line, medial to lateral, in rows in multiple serial lines you must do. This is a right way. Look at this. 3 middle finger held together at a metacarpophalangeal joint flexed, forming a pad of finger with 3 different pressure, light, medium, and deep. So you can feel the cyst lumps. Look at the clock. Urgently, 1 minute you examine a breast, you will miss it. 3 minutes with the way I wrote. Actual time when we did a survey, we found through the ABSI, less than 1.8 minutes a healthcare worker spends to examine, and they miss in inframammary fold, axillary tail, or behind the nipple area complex. So you must discuss this, empower them, and tell them how it should be done. So do it right way. We have enough randomized control trial. I'll not go into the debate, but breast cancer screening saves life. Identifies early where woman can save her breast, can avoid unwanted lot of chemo, immunotherapy, or targeted therapy if you come early. Myths among doctors and patients. Oh, every year 1 mammogram, that itself causes cancer. I always tell everybody, high radiation exposure, very low, even an X-ray gives more, sunlight gives more, 1 rad is all you have, so don't worry about it. If you screen 1,000 women, all lumps are not cancer, 80 are recalled, 10 require further biopsy, 3 are cancer. These are the women you must know. But in India, there is a limitation because there is a dense breast. That's why we have another forms like tomo or piezo crystal or thermo, which we have done. I have presided over as a principal investigator, published a lot of trials on that. Now, if you are a gynecologist or a healthcare worker or a general surgeon, if a lady comes with breast lump or asymmetry, what should you do? God has not given ultrasound at the tip of even best of the best surgeon or a surgical oncologist. So don't think there is a node or not. Your hand says it is cyst or benign or malignant. Please look at it what this particular lump is. Triple assessment is what has to be done. Clinical examination, thoroughly the way I showed. Radiological examination, memo if you are 40 and above when breasts are not dense, coupling with sonomammogram, ultrasound if you are young, and pathological examination and not FNAC, core biopsy, preferably done by you or image guided. Triple assessment. Why should you do triple assessment? Remember, don't go by nipple discharge. Blood discharge has the lowest chance, 0.5% chance of malignancy. It is a postmenopausal lady, unilateral, clear, serous, watery discharge, which has highest chance of having cancer. Mastalgia rarely has a cancer, and only 10% of palpable lumps could be cancer. So most of them are benign. So if you do a triple assessment, that stop that apprehensive lady roaming from doctor to hospital and ending up with an incision biopsy, which is crime in this era of image guided core biopsy, and reassures her and goes home comfortably if you do triple assessment. So second most important thing is don't jump into doing an MRI. MRI is not a first level of investigation. Don't make a woman spend money on that. It should be done by experts in expert cases. And gold standard is triple assessment. You will give good diagnosis, benign, so you go home happily. You don't need surgery, medication. You don't get treated with primrose oil, vitamin E, worse than placebos. And if a lady does a breast self-examination and comes for clinical breast examination, look at the average size where this lump is found to a lady who misses a screening and comes. And we know that invariably it is already stage 2. The average size of the breast lump in India stays at 3.2, coming down, but still 3.2 in an average in India, which is not good. Second thing is learn what is a good mammogram. Don't read the report. Is it properly covering the inframammary fold? At least 2 views. Breast and interpectoral interface is found or not? Axilla is included in oblique view or not? Can you see neck complex? So don't go by a bad mammogram and just seeing a report, oh, I'm happy, Virat 012. Look at it. Is it an ideal? Look at the density. should you need to add an ultrasound? Is the mammogram done? Otherwise, invariably, inframammary fold, axillary tail tumors are missed. Worst is doing a screening improperly and mammography and missing than not doing it. That lady would have come. If you do a scan and say everything normal, that lady says, oh, I have already visited a doctor, I had a memo, I am fine, because you missed it. And then they'll come in advanced disease. So it's very important to understand, to know the density, read your own mammogram, look pattern 1, pattern 2 to pattern 5, and what you should add. Ultrasound of the breast is not synonymous with sonomammogram. An ultrasound for gallbladder, liver, urinary bladder is not same. You must know whether that is a breast imaging specialist. What is the type of the probe they have? Is it high resolution? Are they, trained to do ultrasound of axilla, breast, nipple area complex? Easily, based on the sounds trial protocol, you can identify whether that node is malignant, benign. Is it malignant, benign, taller than, wider, what you are looking at? And what is a true sonomammogram done rightly can rule out it is a cyst, or it is a benign lesion, or it is a cyst with a papillary lesion which needs a core from the solid component, not from the cystic component. Most of the benign lesions can be sorted out, and suspected malignant can be triaged, referred to higher center, right way to do. All the ductal problem, nipple discharge, neck complex, a good ultrasound is beautiful, better than an MRI. Utilize this from a trained person to know a lesion intrapapillary. As I told you, bloody discharge is not the cancer, 0.5%. Watery clear discharge in a postmenopausal or perimenopausal from single breast, you have to look at it. So, if I look in conclusion, triple assessment, clinical examination, right imaging, adding sonomagram in young dense breast, not doing FNA, but doing a core. Even though there are variety, vacuum assisted, ultrasound guided, stereotactic, mammotome, leave it to the specialist, but combine a core of that. Don't jump into an MRI. MRI is not, don't make the woman spend money on that, where the entire treatment in India could be done in the cost of an MRI. Selected right patients you would do if they're BRCA1, BRCA2, or they have breast augmentation surgeries, or they're post-RT, you can't identify induration versus early recurrences, or if they have a silicon prosthesis or an MUO adenocarcinoma axilla, selected cases you need to do. Don't overuse them. Second, please don't do FNA. Please do core biopsies. It is very image guided, or at least office based yourself. From ABSI, we run the skill courses for gynecologist, general surgeon, how to do a core biopsy. Very simple and easy, outpatient, office based, avoids unwanted dilemma, false, positive, false negative, unwanted incisional biopsy. We run in our each ABCCon, and we also bringing our ABSI guideline how to do core biopsy and imaging for breast surgeon. You can utilize this and do. We also bring this first of its kind 3-arm study, Indian solution for Indian problem. No radiocolloid, no handheld gamma probe, blue dye alone. ICG available in India in a medical college setup, trained. This is a landmark study published in Clinical Breast Cancer from our group through ABSI. And also this is adopted in the Oxford written meta-analysis, Indian solution for Indian problem at low cost, periphery you can practice and give the benefit. So I want to end to say that do a good triple assessment. So big scar open biopsies are avoided. You can plan a proper breast conservation. This is not an era where you keep an incision wherever you want. Oncoplasty incisions, avoid 2 procedure. Cost is less eventually instead of doing 2 procedure. And that itself may be the single reason a woman may actually retain a breast. Thank you very much, and best wishes from ABSI Association.
Thank you so much, sir. I think that was a real wonderful presentation. Such beautifully explained what a woman should do and how they must undergo the triple assessment, because we understand the message is very clear that most of them would be benign, and we need not worry, and the lady should not be forced to take up MRI, and the entire treatment can be done very easily. I think that's a wonderful message for all our audience, even for the non-medicals, all the non-paramedical, and that they should not really worry and should take this guidelines very clearly, that they must undergo proper examination before making conclusion whether it is a breast cancer or it is something else.
I also welcome everybody November to Calcutta, where we have a ABCCon on site, and over 10 travel fellowships from ABSI to world over. And also to read every 3-4 years, we bring ABSI consensus guideline by a panel of 20 top experts in India by debate, re-debate, Indian evidence, Indian solution. Please read them periodically as and when they get published. Thank you.
Thank you so much. I think
compliment Dr. Somsekhar. Excellent talk and a lot of take-home points. I mean, I think that is what was required, what was expected. Thank you so much.
Thank you.
With this, now we move on to our next scientific session, which is on what and when to order for imaging of breast. And for this, I would like to invite Dr. Smriti Harish. She's currently professor at All India Institute of Medical Sciences, in charge of fully equipped breast imaging facility at AIIMS, has more than 52 publications and 12 chapters, index journals, and textbooks. She's founder General Secretary of the Breast Imaging Society of India. With great applause, I would invite ma'am to kindly give her talk. Smriti ma'am.
Yeah, thank you so much for the kind introduction. And I think Dr. Somsekhar has really made my job very easy. He talked a lot about what is to be ordered and when. So I will only be reiterating what he has said so far. I'm trying to get it to slideshow. I hope the slide is visible now.
Yes, ma'am. Perfectly visible.
Okay. So just like Association for Breast Surgeons was formed, the breast radiologist had felt the need for a society which brings together all the breast radiologists, and that was formed in 2012. I was the founder general secretary, and we are doing work towards bringing quality breast imaging, and which is uniform all over India. And a step like this, where we are sharing which imaging modalities should be used when with the referring clinicians, is a step in that direction. And I thank the organizers for giving me an opportunity. So the available imaging modalities for breast evaluation, we all know, are mammography, ultrasound, and MRI with contrast. So for mammography, I would like to say that we should go to centers which offer full field digital mammography preferably. Other centers are you doing pseudo, I mean, it is a pseudo digital mammogram, because what is being done there is computed radiography is being used. Cassette readers are being used to turn an analog image into a digital image. That is also fine, but most of the times the cassette readers being used are not the ones which are approved for mammography. So that leads to poor quality of images, and we should avoid going to such centers. What to order and when, I have divided into two settings. One is the screening and one is the diagnostic, when a lady is coming with symptoms. So the American College of Radiology has published ACR appropriateness criteria for each clinical condition. And these are evidence-based guidelines for choosing the most appropriate imaging modality for a specific condition. This provides direct evidence-based guidance to referring clinicians. And the good thing is that these guidelines are updated every 3 years so that they are abreast with the most current advances. In the screening recommendation depends on the risk of the lady. So how is that risk calculated? There are various models, computer software based, which calculate the average, the lifetime risk of breast cancer based on the age, the presence of any high risk lesions like atypical ductal hyperplasia or NCIS, or especially any family history, breast cancer in first degree relatives. So based on that, the average risk women are those who have less than 15% risk of cancer. For them, the screening mammography should start at 40 years and it should be an annual mammogram. The women with high risk, those who are more than 20% risk, they should start at 25 years of age, much earlier than the ladies with average risk, and they should start with an annual MRI. because MRI has the highest sensitivity in such dense breasts. After 30 years, mammography is added annually, and the appointments are done so that there is a gap of 6 months between the mammogram and the MRI. There are few ladies who have an intermediate risk, that is, the risk is slightly more than average. These are the women who have a past history of cancer, who were treated for breast cancer, or who have some genetic history, but which is not so strong. So for them, we can start the screening before 40 years, and we may consider MRI if the breast is dense on mammogram. Tomosynthesis, everybody is getting to know of this new advance in mammography, wherein we are able to get slices of mammogram, something like what we get in CT, rather than a single mammogram. So this definitely increases the rate of cancer detection and decreases recall in women of all ages. Ultrasound again can be used as a supplementary modality for women with dense breast. And as the speaker before me said, in India, the breast cancers are occurring in younger women, and we face the problem of having to look for cancer in dense breasts very much. So ultrasound does increase the cancer detection rate, but we must remember that it substantially increases the rate of false positive findings. That is, findings which are not cancer, like small fibroadenoma, small cysts, and some of them may increase our biopsy rate. Now coming to the symptomatic women. By symptoms, I mean a lady coming with a problem to a doctor related to the breast. So the choice of modality greatly depends upon the age of the woman. So for that purpose, we can divide the women into 3 categories. The ladies who are less than 30 years, they should undergo an ultrasound first for 2 reasons. Most of the abnormalities in this age group are likely to be benign, and mammogram is not likely to work in this age group because of the density of the breast. So first do an ultrasound, and if you find a benign pathology, that is it. You don't need to go further. If you find any suspicious lesion which you think could be cancer, then mammography should be performed in this age group as well, because there are findings like microcalcifications which you may not see on the ultrasound, and that would have a bearing on the extent of the disease and the type of the surgery which the woman would need. So mammography is not contraindicated, but not preferred in ladies less than 30 years. On the other hand, if the lady is more than 40 years and she has breast symptoms, mammography should be offered first. And often it is supplemented by ultrasound because it further helps in characterization of the abnormalities. The age group of 30 to 40 is where you can either do an ultrasound or mammography first, which could be depending upon the radiologist's choice, depending upon the symptoms. For example, if the symptom is nipple discharge, I would choose to do ultrasound first. So that choice lies with the radiologist. As Dr. Somsekhar said, breast pain, if it is non-focal, diffuse or cyclical, imaging is not required at all. All that is needed is reassurance to the lady. But if the lady is having pain which is focal in nature, it is non-cyclical, then we need to investigate. And again, ultrasound should be the imaging test before 30 years age and mammography after 40 years. Same way, in a palpable mass, it is depending upon the age. First ultrasound in younger women and first mammography in older women. What happens if you have a palpable mass, but the mammography and ultrasound are both negative? So in this, first we should ensure that definitely the area of palpable concern has been imaged and has been seen on ultrasound, because sometimes it may be in the axillary tail or the inframammary fold, and it may not have been imaged properly. Secondly, the negative predictive value of mammo and ultrasound in the context of a palpable mass is quite high. So the chances that the woman has any abnormality are very low. But nevertheless, a negative imaging evaluation should never overrule a strongly suspicious finding on physical examination. If you have a definite finding on the palpation, you can go ahead and do a biopsy, a palpation-guided biopsy of that finding, even if the mammography and ultrasound are negative. What about males with palpable breast mass? So males often present with gynecomastia, which is bilateral and which can be clinically diagnosed. Gynecomastia does not require any imaging. If there is a palpable breast mass, which is unilateral, which is eccentric to the nipple, they do need imaging. And again, in men before 25 years, we do ultrasound first. And in men above 25 years, we do a mammography and ultrasound if required. I would again like to say that the tissue sampling of suspicious masses should be done with core needle biopsy. It is superior to FNAC. FNAC has been given up in the developed world for biopsy of breast masses, because the pathologist requires a good amount of tissue to make a definite diagnosis and to give you the hormonal status in case it is a malignancy. Preferably the imaging should have been done before the biopsy, because the biopsy related hematoma changes can confuse or limit image interpretation. Plus, mammography would be painful for a lady who has just undergone biopsy. And imaging guidance is recommended for even palpable masses because it improves accuracy. When you take a sample under palpation, sometimes you are not into the correct area and you are only cutting the induration, or you are in the necrotic region. So these could lead to repeat biopsies for the patient. So in my hospital, we practice image guidance for even palpable masses. What do we do if a pregnant or lactating lady has a palpable mass? I would say, first of all, we should not ignore any mass during pregnancy or lactation. We should not assume it to be benign. We should not put it on the pregnancy and think that it is galactosele only or a fibroadenoma, because we know that the milieu of the breast with so much of hormonal stimulation is very ripe for cancers as well. So we should examine these women promptly, and ultrasound would be the modality of choice. Mammogram can be performed if the ultrasound shows suspicious findings, again, because we would like to see the complete extent, any additional disease. So mammography is not contraindicated either during pregnancy or lactation. As it is, mammography has a very, very low dose, and the fetal dose is minuscule and is not a problem at all. Even then, some people like to cover the abdomen with a lead shield, so that is also okay, though not required. MRI is contraindicated during pregnancy because of the IV contrast that is required. It is not safe for the fetus, but MRI can be performed during lactation. High-risk women, however, should continue screening during pregnancy and lactation with their protocol of MRI and mammography.
With contrast.
Coming to nipple discharge, again, we must make sure what kind of discharge it is. If it is physiological discharge, which is non-spontaneous, which is bilateral, imaging is not required. Only some reassurance is required. But if it is pathologic, where the nipple discharge is coming only from one breast, only from one duct, and is serous or bloody, and is most importantly spontaneous, that means the lady gives you a history that it stains her undergarments, then imaging is very much required. And in women less than 30 years, ultrasound is the first modality. And even in women more than 30 years, we can do mammography, but ultrasound has a more important role, and it has to focus on the areola and the region behind the nipple, and you need good high resolution ultrasound to look for this area. There are cases when a woman has clear pathological nipple discharge, but the conventional imaging, which is which mammography and ultrasound, is negative. So what is done in these cases? There are now two choices. Most often these ladies undergo radical duct excision, but sometimes the pathologist may not identify a discrete causative lesion for the discharge after the specimen reaches the pathologist. And women of childbearing age would not be desirous of undergoing a major duct excision. And in up to 20% patients, the lesion which is actually causing the nipple discharge is more than 3 centimeters beyond the nipple. It is peripheral, so to say, and therefore it may not be excised by this procedure, which takes out the major ducts up to maximum 3 centimeters from the nipple. So MRI is a very good modality, which when used judiciously comes to our aid, because here we can see the peripheral ducts. We can have a ductogram-like picture by using heavily T2-weighted sequences, and the lesion localization is more accurate. So the chances that we are not addressing the causative lesion will come down markedly. So MRI has a role where conventional imaging is negative in patients with pathological nipple discharge. The tissue sampling of intraductal masses is very tricky because the pathologist requires the tissue at the periphery, at the periphery of these papillae, to be able to say whether they are invasive or not. And that is, FNAC is a big no. Even core needle biopsies often undersample these lesions. So vacuum assisted core needle biopsy is quite useful in this regard. And in the vacuum assisted core needle biopsy, often you remove the whole lesion and it ends up being curative as well. So if you do not have vacuum assisted biopsy, sometimes it is often better to go for an excisional biopsy instead of CNB, so that you give adequate sample to the pathologist. What is the imaging required before breast conservative surgery? The most important thing we need is an accurate evaluation of tumor size and the multifocality, multicentricity of the tumor has to be ruled out. In this, ultrasound is complementary to mammography in showing additional lesions and is often sufficient, and you don't need anything more. But there are some patients where preoperative MRI is recommended to be used judiciously, and some of the indications are when the breasts are extremely dense and you cannot make out the extent of the tumor to your confidence. In high-risk women, because they are likely to have multifocal or multicentric cancers or even bilateral cancers. Invasive lobular cancer is also notorious for being multifocal, for being bilateral. So it is a good idea to do a preoperative MRI in case you are wanting to conserve the breast. Finally, I say that if the clinical examination, the mammography and the ultrasound do not match up regarding the extent of disease, you could use MRI as the deciding modality. But it is to be remembered that if you detect any additional findings on MR, you should not convert your conservative surgery to mastectomy just based on the findings, unless it is proved by biopsy to be malignant. because MRI has a high sensitivity but a moderate specificity. Many of the benign lesions will also enhance and look like cancer. So you may have, you should definitely prove those lesions by biopsy. 50% of the times these additional lesions can be seen on second look ultrasound, and ultrasound guided biopsy can be performed. If not, MR only seen lesions have to undergo MR guided biopsy. When a lady has early breast cancer, what is the imaging she requires for staging? In stage 1 and 2, apart from the local extent, an axillary ultrasound and biopsy is needed for nodal staging, and there is no need for routine metastatic workup if there is no symptom. Only if there are symptoms, focal symptoms, specific imaging should be performed. On the other hand, in locally advanced breast cancer, stage 3 and 4, apart from the local staging, the axillary ultrasound, one needs to do some metastatic workup. CT chest and abdomen and bone scan do very well for metastatic workup. If you have the easy availability, FDG PET-CT is recommended as an alternative.
Ma'am, just a small reminder for time check, please, because we have to space schedule on time. So
2 more.
Just a reminder.
Yeah. Lastly, post-treatment surveillance for local recurrence. There should be post-treatment surveillance with mammography. First, mammogram should be obtained 6 months after completion of chemotherapy and radiotherapy. And after that, annual mammography. When BCS has been done with or without autologous reconstruction. There is no role of mammography on the side of mastectomy without reconstruction. Lastly, a word about breast implants. Most of the implants these days are silicone implants. Asymptomatic patients do not require any imaging. If there is a suspected rupture, MR without contrast is the gold standard. This is the only indication where MRI is performed without contrast. And with that, I would like to end. Thank you.
Thank you so much, ma'am. I think that was a very wonderful, comprehensive presentation, very beautifully explained about how the test and diagnosis should be done for the person. Thank you so much for your valuable time, ma'am. And with this, I would like to invite Dr. Professor Sandeep Kumar. He's ex-professor of surgery from King's George Medical University, Lucknow. Sir is a renowned surgeon specialized in breast cancer, general surgery, and laparoscopic surgery. He undertakes all types of breast surgeries and breast-related consultations at Lucknow. He is currently also the founder director at All India Institute of Medical Sciences, Bhopal. He was awarded with the Rockefeller ICanCaRe Fellowship in 1990, and with this, he did a second master's degree in clinical epidemiology from Newcastle, Australia. He has also been awarded with the National Academy of Medical Sciences, Paul Sangram Lal Memorial Oration 2014, Dr. S. Radhakrishnan Memorial National Teacher Media Award in 2013. He has had more than 100 research papers published to his name and contributed chapters in several textbooks. He's a prolific speaker and has been invited to speak in several universities and colleges in India and overseas. We're privileged to have Sir at the International E-Conclave today, and would like to invite for the scientific session on clinical approach to plastic. So just a small request from our end, because we're running late, so I'll request you to be kindly be brief about the topic. Thank you.
Shruti, for being late. I was stuck in traffic. I'll try and finish very quickly. My greetings to all my fellow speakers, Dr. Hari, Dr. Soma Shekhar, Dr. Iqbal. I'm aware of the fact that you're running short of time, so I would like and finish as soon as possible. My topic is nostalgia, etiopathogenesis, and treatment. Is my slide visible? Are you able to see the slide?
Yes, sir, it's absolutely visible.
Breast anatomy is a modified apocrine gland lying over the pectoralis major muscle. It has an axillary tail, a nipple and areola complex, suspensory ligaments, and glandular tissue, and a lot of adipose tissue above the superficial fascia of the breast. Breast has 3 major components: the epithelial tissue, which proliferates and becomes benign lump or a malignant lump; fibrous tissue. There is a paracrine activity between the epithelial and the fibrous tissue, leading to Within breast edema and breast pain and many things, there are collecting ducts, terminal ductular lobular units. There is a saccule at the terminus and about 8 to 10 lactating ducts. There is a lot of adiposity. Breast is an end organ for the activity of estrogen, progesterone, prolactin, maybe LH and FSH, maybe growth hormone in earlier stages, and some other hormones as well. So breast is amenable to hormonal treatment. Presentation of problems has been illustrated. Pain and lumpiness, probably when I say lumpiness, I want to have it separately seen than from a discrete lump. A discrete lump is a lump that one can hold between thumb and finger. A lumpiness is a lumpiness that is felt on a flat of the hand palpation, where the breast texture is not that smooth. Discharge from nipple, discharge elsewhere from the nipple, axillary problems with an extra axillary breast or a mond, lactational issues, cosmetic issues, deformity of breast and skin related problems, nipple and areola related problems. Abnormal mammogram is a common presentation in areas where breast screening is routine, and abnormal MRIs is a problem that has just been alluded upon by Professor Smriti Hari. Breast has overt diseases like breast cancer, fibroadenoma. Breast has trivial problems because women worry about breast and there may be really nothing in the breast and they may simply somatize the symptom. So a breast physician and gynecologist has to be aware of the fact that many a times they simply have to reassure the person that there is nothing in the breast, or it's just a trivia or a little pain, but there is a huge gray zone of the breast problem, and mastalgia falls in that gray zone. Mastalgia may be very trivial, which just simply needs reassurance. And as was just said by Dr. Hari, pure plain cyclical mastalgia with no palpable lump in a young person may simply need reassurance, revisit, and reassessment clinically, and may not even require a sonogram or a mammogram. So mastalgia is a common condition. Mastalgia is a part of the aberration of normal development and involution. It is largely cyclical mastalgia, which occurs premenstrually. It is mostly hormone dependent. Mastalgia can be and usually is associated with nodularity. Rarely fibroadenoma is painful. 10% of the breast cancer can be painful. Majority of the breast cancerous lumps are painless. Congenital deformities, cosmetic quests. Breast abscess is painful. Breast abscess can be purpural, non-purpural. Both can be mastalgia. Breast abscess can be tubercular. Ductectasia, papilloma, cysts, glandular mastitis, sclerosing adenosis, cystosarcoma, tuberculosis, fat necrosis are discrete pathologies which also present with breast pain, usually non-cyclical breast pain. This was referred to by Dr. Hari as pathologies, and she said these can be diagnosed by the algorithm she discussed. So I will move on to the mastalgia. We developed a visual analog scale to assess nodularity, and this scale has now been adopted. It is now in Bailey and Love and many other textbooks. It is a pictorial scale. About 40% of the breast are non-nodular, 10 to 20% breasts in women in an epidemiological study that we conducted have grade 1 nodularity, grade 2, grade 3, grade 4. Most of the nodularity shown in these pictorial schematic cartoons is in the upper outer quadrant, and so is the case. Majority nodularity is in the upper outer quadrant. The inter-observer variability of this chart is extremely good with a very little kappa variation, 80% agreement. And if this chart is kept in front of breast physicians, they usually concur and they usually agree. And this was tested with about 30 breast surgeons doing blinded breast nodularity scale testing. And this scale was published and it's now in some of the major textbooks on breast disease. We examined total, so I will not go through this because of the paucity of time. The the details of the study. The etiology, again, I will very quickly go through. Is it a non-entity? No, it is definitely an entity. Is it psychoneurosis? No. Women presenting with breast pain are no more extra depressed or having a psychogenic origin of their breast pain. They sincerely suffer from breast pain. This has been proven by administering psychoneurotic scales to women who present with mastalgia as opposed to women presenting with hernia and gallbladder disease. So the such kind of writing that occurred in Jeffcott's book of Gynecology and Atkins, that it occurs in frustrated, unhappy, nullipary women and women with breast pain are of irritable and suggestive nature, should not be taken into account. We have to respect women and their symptom of mastalgia, and we have to find out whether it's a cyclical or a non-cyclical mastalgia. Is mastalgia a water retention? Deuterium studies published in British Medical Journal have shown that mastalgia is no extra water retention like cyclical edema, pedal edema in the third space. Dietary factors may do cause mastalgia in some cases, but mastalgia indeed is some kind of a hormonal imbalance. But this hormonal imbalance, may I say here, and I think that should suffice, is not detected by one-off hormone levels in the blood because of huge diurnal circadian and circadian variation of the hormones. The hormonal imbalance is a very subtle imbalance, and this has been detected. Dietary manipulations by using low-fat intake, gamma-linolenic acid, and restriction of caffeine and methylxanthines may, for a short while, abrogate breast pain, but that is a milder form of breast pain. It is not true that obese women, women with more cholesterol and triglyceride in their system suffer from breast pain more as opposed to thin-built women. So dietary manipulations generally are not successful, whether it is abstinence from tea, coffee, or excessive use of gamma-linolenic acid. This was just said by Dr. Somashekhar as well. And mastalgia, as done by these MRI studies and by deuterium studies, is not water retention. Mastalgia is probably hypothalamus, is a cyclical mastalgia, is hypothalamus, pituitary and breast axis, probably ovarian axis. Is it unopposed estrogen activity because of the inadequate corpus luteum? You know, corpus luteum is formed in the second half of the menstrual cycle with more progesterone. Estrogen is a mitogenic hormone which causes nucleus to divide, whereas the progesterone brings the cell into the stage of cellular rest. And is it, the third theory, is it increased prolactin in the system? But none of these hormones, if you assess just by doing random assessment of patients with in control subjects in cyclical mastalgia, non-cyclical mastalgia, there is no statistical difference that we have demonstrated in large number of studies, at least 3 studies that we published, between controlled cyclical mastalgia and non-cyclical mastalgia. The levels of estrogen, progesterone, and prolactin do not differ. So what is really the problem? The problem is the pulsatility of the secretion of the hormones, the diurnal variations, the change of hormones because of the emotional stage, change of hormones in the circadian and the circadian rhythm, which is the monthly rhythm of the hormones in women because of the menstrual cycle. Hormones are difficult to assay because of the intra and inter-assay variation, and the hormones have a huge, a very long range of normalcy, and exogenous administration of many drugs, pills, and thyroxine may alter the hormone, the interior hormones in a subject. So what is it otherwise? Is it unopposed estrogen activity? So it probably it is. Whenever there is a menarche and there is a menopause, the corpus luteum is inadequately formed and the cycles become anovulatory at the early time of menarche and at the time of menopause. And because there is no progesterone in the system, so there is excessive estrogenic activity. And this is proven by the fact that the drugs like which are anti-estrogen, tamoxifen, centroman, and many such drugs completely abate mastalgia, which has been shown by several trials. We've studied these hormones doing urinary metabolites, morning level, evening level, 24-hour levels, daily blood salivary, because hormones come into saliva. These are known as secretagogues, and random stimulated, uninhibited, sleep-related, and response to substances like GNRH. And what I would be telling is a summary statement of what hormones go wrong in mastalgia. Also, besides that, there may be abnormal levels of hormones or abnormal triggering of the hormones at certain stage. There can be an abnormal target tissue response because only one breast may be more painful as opposed to the other breast. In clinical examination of mastalgia, you have to see whether it is a costochondritis, which is known as Teats disease, whether it is a bony skeletal pain of a person suffering from osteomalacia, especially in lactating women, whether it is a tenderness of the breast because of the pregnancy, or whether it is truly a mastalgia, which is non-physiological mastalgia in the parenchyma of the breast. And a clever person who's done clinical examination should be able to decipher this difference. These are some of the publications on the etiopathogenesis of mastalgia. So as you can see, the peripheral levels of hormones in the venous blood do not differ. But if you do certain tests like domperidone test, TRH test, then there is a greater excitability in the system and the prolactin shoots up much more higher in subjects with cyclical mastalgia shown by hollow circles as opposed by control population. And this is the basis of the action of the dopamine agonistic agents like bromocriptine and pergolide. So we did assessment of ovulation over a full period of cycle in a large number of women, and we looked for the corpus luteal insufficiency, and it is there in a very subtle manner, but not really there. So that's the reason why mastalgia occurs and why these drugs act. Drugs like bromocriptine, drugs like tamoxifen, drugs like centroman, which have been shown in randomized trial to be effective. Treatment of mastalgia has gone through a radical change over the last 4 decades. It all started with drugs like B6 and gamma-linolenic acid and evening primrose oil, but randomized trials published by these people and republished by the same people, they have retracted their evidence that evening primrose oil or vitamin E has any role in placebo-controlled trials to treat mastalgia. Whenever you treat mastalgia, exclude a discrete lump, exclude cancer is the primary duty of a doctor. Majority mastalgia can simply be treated by eminent reassurance, telling the person that you have to tell me when I'll stop in 2 minutes. Shruti, I can see your lips. Reassurance is the main sheet anchor of the treatment. Women with mild to moderate mastalgia has to be told clear-cut reassurance that they do not have cancer. Drug treatment is required in only 10% of the mastalgia and surveillance for high-risk benign breast disease. These are some of the putative agents to treat mastalgia. Tamoxifen, centroman is the one I'm going to talk about. Aromatase inhibitors. Progestrogens, no better. Bromocriptine is good, which is a dopamine agonist. Danazol has lots of side effects. It makes the breast look a bit doughy and the breast becomes shrunken, and women has hirsutism. So this was a popular drug 2 decades ago. No longer it is used. LHRH analog is too big a shot for a disease like mastalgia. Prostaglandins, primrose oil, B6, methylxanthine withdrawal, coffee withdrawal does not help. NSAID, opioids, calcium D3, flagyl, antidepressants are used as adjunct whenever required if those are the associated conditions and associated morbidities. I will skip the basis of the action of these agents looking at the time constraint, I will straight away come to the number one drug, which has been done by an extremely tight randomized controlled trial. Now 4 or 5 more trials after we did our trial have confirmed that this wonderful agent made in the city where I live is Lucknow, made in CDRI, Indian agent, which has actually promulgated initially as a once-a-week contraceptive, later on as a morning after pill, and also as an anti-decidual agent, is also an anti-cancer agent. It is a SERM, it is a selective estrogen receptor modifying agent. It is sold as contraceptive pill by the name Saheli by HLL. For breast disease, it is sold as Novex 30 milligram. For menorrhagia and menstrual bleeding, it is sold as Novex TS. In trials, people have used it twice a week. But this particular agent, I must emphasize, has a very huge half-life of 147 hours, and it's as effective. It has no toxicity even if you use it daily, but it must be used, and it should be used at once-a-week dosage at 30 milligrams. So Novex is your drug of choice, one and the only drug. We are lucky to have it in India. Americans are struggling to have this drug. They're doing their trials at the moment in California. We did a trial. I'll not go into it, but I'll just show you that we did a very tidy trial. And these are the results of the abrogation of nodularity and the abolition of mastalgia in 5 subsequent visits, where up to 6 months the women were followed. It was a drug and a placebo-controlled trial. And you can see at the beginning, at the first month, second month, within 6 months, there's a clear-cut separation, and the patients who are in placebo, as compared to those who are on active drug, continue to abrogate with pain, and they have a clear-cut benefit in their pain scores and their abrogation in their nodularity scores. So this trial has been published. These are the results with p-values, with sophisticated analyses. So what really is mastalgia? Mastalgia is a disease of a modern woman who hangs around with not getting married till the age of 30, 35. So they keep on altering their menstrual cycle. So the hypothalamic pituitary ovarian axis and stress, of course, leads to some subtle increased prolactin and estrogenic environment in the body, leading to breast pain. That's it. Thank you very much.
Thank you so much, sir. That was a total spellbinding session. So much of knowledge in such a short span of time. I think you have beautifully explained the subject, and I'm sure that all of our audience would have really learned a lot. We would have loved to hear from you. But then now I would like to really call Dr. Meenu to give the chairperson's remark for the scientific sessions.
Thank you all the speakers today. We had some of the best faculty of the country and from some abroad also. And it has been a wonderful experience. We are already running very late. Otherwise, I would have loved to recapitulate the main points. The only take home I say for everybody is, remember which age, what to do, what investigation. Very beautiful points brought by Dr. Smriti Hari. And plus, not to under-evaluate the value of triple assessment and how to proceed for mastalgias and breast diseases. Wonderful sessions. And without wasting much time, I'll over to you for the further panel discussion. And let's try to keep it as short as possible.
Yeah. Thank you so much, ma'am. Thank you so much for the chairperson's remark. With this, now we move towards a very the most awaited session for the evening, which is a panel discussion. For this, I would like to invite our chairpersons first for the panel discussion to chair the session. We have Dr. Jayam Kannan, who is Emeritus Professor at Tamil Nadu, Dr. MGR Medical University, Chennai. Ma'am is post-director of the course of fellowship in reproductive medicine, also a consultant at the Garbha Rakshabambi Fertility Center. Currently, she's handling three important projects, which is on long-term follow-up of PCOS. She started the study in 2001. Currently, 1,100 patients are being followed up. Efficacy of intravenous iron therapy in pregnant women. And also in prevention of preterm labor. She's an active teacher in FOGSI and also an active member of American Fertility Society, American Andrology Society, FIGO International Society, and more. Ma'am is winner of the National Merit Scholarship in 1962 and also the winner of President of India Award in 1968 for Best Student in Medicine. Next, I would like to invite another prolific chairperson on the dais, Dr. Jaydeep Tong. Currently, Sir is consultant at Ashwini Maternity and Surgical Hospital Center for Endoscopy and IVF. Sir is consultant at Jupiter Hospital Fertility and IVF Clinic. Program Director and member of Board Profert, IVF Past Secretary General of FOGSI. Vice President of Mumbai Obstetric and Gynecological Society. Chair International Federation of Obstetric and Gynecology, Working Group for Safe Abortion. Deputy Secretary Asia Oceanic Federation of Obstetric and Gynecology. And also the recipient of Young Gynecologist Award in 2000, FIGO Fellowship Award, and Korean Award in 2000. We welcome both the chairpersons on the dais. Next, I would like to introduce all our esteemed panelists for the evening. For the panel discussion, we have Dr. Vanita Kapoor. She's Senior Consultant Radiologist at Colonel Pant Imaging Center. She's also Senior Consultant Radiologist at Rural Medical Center, Sedjala, and Medical Director at Hygiene Healthcare. Dr. Usha Agrawal, Scientist and Director, ICMR, National Institute of Pathology, New Delhi. Ma'am could not join us because of an urgent meeting with the director at ICMR. However, she has sent her good wishes and blessings for the session. I would now like to invite Dr. Navneet Kaur, Professor of Surgery from University College of Medical Sciences and GTB Hospital from University of Delhi. Dr. Jyoti Panglowala, currently Secretary of the IOGS. Dr. Gaurav Agrawal, Professor of Forensic Medicine and Medical Legal Specialist and Lawyer from NCR Institute of Medical Sciences, Meerut. We also have, I'll also invite Dr. Iqbal Kasana again, consultant of breast onchoplastic, reconstructive and breast cosmetic surgery from Walson Manor Hospital to join the dais. With this, I invite the moderator for the evening, our own Dr. Geeta Shetty. She's onchoplastic and reconstructive breast surgeon. Sorry. She's onchoplastic and reconstructive breast surgeon, consultant at Sandwell and West Birmingham NHS Trust UK. Ma'am is currently the honorary senior supervisor at Edinburgh University, also the honorary senior lecturer at Edge Hill University, and professor of surgery at Manipal Academy of Higher Education and Kasturba Medical College, Bangalore. I hand over now the session to Dr. Geeta Shetty, ma'am, to kindly take the discussion ahead.
Right. Thank you very much. I hope everyone hears me now. Hear me now here. Is everything okay? Am I?
Yes, ma'am.
Yes.
You're
okay, perfect. So I got this half an hour and I got 3 scenarios to cover whole of the theme. I'll try to keep it on time. I'm putting the timer. Okay. So we are going to shoot the questions and take home messages. Okay. That is what I'm aiming for in interest of time. Thank you all panel members. I'm going to share the screen and good to see you all. I know Navneet from before, obviously. I know my colleague Iqbal, and good to see the other panel member, Dr. Vanita, Dr. Jyoti, and Dr. Gaurav here. Okay, and I'm going to share the screen.
Dr. Geeta, while you're sharing the screen, can I just make a couple of comments and then get out of your way? Given that.
Oh yeah, please don't. Yeah, by all means.
So thank
Shruti,
you.
Can you allow me to share the screen? It says only one participant can share the screen.
Yeah, ma'am, it's done now. Jaydeep sir, please go ahead.
Yeah, so thank you very much to the organizers for having me and Dr. Jayam Kannan here. I thought I could do the introductory remarks and then Dr. Jayam Kannan could do the closing ones. And let me thank all the organizers, all the collaborating organizations, and all the moderator, Dr. Shetty, and the panelists, Dr. Kapoor, Agarwal, Dr. Dayal, and Jyoti, and Dr. Gaurav. I think this is going to be a very interesting session because it probably has answers to a very loaded question of what is in the purview of a gynecologist. And I think this has always been a fairly controversial area with surgeons and gynecologists both claiming that the breast falls under their purview. Truth be told, it should be a partnership and a fruitful one at that, but I will leave it to the moderator and the panelists to answer the questions. Thank you very much.
Thank you, sir, and a very warm welcome to you from ECon-Breast, Dr. Jaydeep sir and Dr. Kannan ma'am. I will not stand in your way, Dr. Geeta, but We have such stalwarts amongst us. Thank you so much for blessing us with your encouraging presence.
Thank you. And Dr. Jayam Kanan is here, so she will do
Yes,
the wrap up. Hi, Dr. Jayam.
Good evening. I just had to return from Noida. That's why this is. Thank you very much for giving me the next opportunity in the breast conference. I also attended the first one on the 5th and the second one on 9th. And the breast problems are very close to everyone's family also, because my family has 3 members who have been treated for breast and are continuing their life for the 3rd decade. So this is a very area which is very close to my heart, and I'm very grateful to Jaideep for giving me an opportunity to talk in this session. I eagerly wait for the panel by Geeta and learn more from her. Over to the organizer.
Geeta, your mic is off. Geeta, your mic is off.
Ma'am, please unmute yourself. You're on mute.
Yeah. Can you see my screen?
Not yet, ma'am. Not yet.
I did share it. Okay, share. Can you now?
No.
No, not yet.
I'm having the trouble to share the screen now. I thought I was okay. Share. Okay, let me do it again.
Probably your PowerPoint has been
sharing the
stuck.
screen. Retry it again. Okay, I'll try one more time. Otherwise, Shruti, you got the PDF file. You can start. Okay.
Yeah.
Just keep the things ready for me. Okay, I'll try my best. Again, share. Can you see that, please? No?
Okay.
Can you see my screen, please?
No. See whether
Not
you
yet.
can unmute and come back.
Can I share? Should I share on your behalf?
Yeah, you can share. Go ahead and share, please. I don't want to delay the session already. It is coming as failed screen share. I don't know, is it on from my side or your side? Yes, that's fine. Okay, I'll just put the timer and get going. Right, so that is the theme, benign lesions. What is the purview of the gynecologist? Already our esteemed chair they have talked about it, why we are here. So we are going to have 3 scenarios, as I explained earlier, and then going to take it from there. The first scenario, right? So 39-year-old woman with bilateral breast pain and right breast fullness, no discrete lump, right breast fullness, outer half of the breast since 6 weeks. This is her complaints. Okay, her background history, multipara, 3 children, intermittent OCP for nearly 10 years, family history of mother being diagnosed with a breast cancer. So what are we thinking in this? And her clinical examination is a vague lump in upper outer quadrant, more prominent on the right than left. There is no discrete lump, it is just, upper outer quadrant fullness. Bilateral axillary and supraclavicular fossa examination, unremarkable. What is the working diagnosis? Let's take it from Jyoti, and then we will move on to Navneet and Iqbal, please.
Yes, it is the working diagnosis is always fibroadenoma, seeing the age group of the patient. But seeing the history, family history of her mother, we have to do assessment from the radiological view also. As she is having history of the mother having.
So one of the things you are saying, it is a fibroadenoma. It is just a right breast fullness, which is more prominent on the right than the left.
Without
any other things comes to agree. Any other diagnosis?
We should have a detailed history of oral contraceptive pills, or is she taking any antipsychotic drugs, or is she taking any hypertensive drugs? As she is 39 years age, after 35, many of women in our country are facing the hypertension problem. So is she taking antihypertensive drugs, or detailed history of drug intake and menstrual history? Menstrual history to be considered as for the oral contraceptive pills, uses of oral contraceptive pills, as you say. So this should be also mentioned.
Yeah, in this scenario, we have the intermittent oral contraceptive pills for 10 years because she got 3 children. She probably had it in between and all no other significant history. But I can understand that the benign disease comes to the things in the first thing. She's 39.
Always first we think about the benign disease, but she is having family history of her mother being CA patient. So the detailed evaluation of the history and then detailed clinical assessment should be done.
Perfect. Okay. And Navneet, any other things you can think of?
Yeah, clinically, I think we should consider both the possibilities. We have to keep the history of OCP intake and family breast cancer in mind. And this is also the age when there's a lot of normal involutional changes. And since on examination as well as patient's complaint, there's a wakefulness. So we have to consider the possibility of a nodularity, whether it is a proliferative lesion with or without or with ATPR. And we also have to think the possibility of a malignancy in the breast. So I think these are two foremost. The other differentials of a breast lump, but we will put them lower in the category. And next would be to go for a triple assessment.
Lovely. Next slide, please. I'll come to Iqbal for the next further question. Right. Yes. See, we got both the kind of working diagnosis, benign breast changes, fibrocystic or cystic disease of the breast. You can call it a nodularity, whatever. And then malignancy is the other things which comes to our mind in this scenario. What are the imaging in 39-year-old? Iqbal, what would you do?
Well, we do the ultrasound scan as a standard. We don't do mammogram below 40. So mammogram is reserved for 40 and above. But if we find anything suspicious on ultrasound scan, which points towards a malignancy, then we do a mammogram as well. And of course, proceed to biopsy, ultrasound guided biopsy.
Do you concur with those comments, Dr. Navneet?
Yeah, more or less, I think though 40 is the age which is taken as a cutoff, but there's nothing, I would say, so specific about that age 40. She is multipara. She has had 3 children, so her breast is not going to be very dense. So I would not completely rule out the need for a mammogram or the request for a mammogram, but definitely ultrasound would be the first modality of choice. Especially for palpable lumps, I think that's the first thing we should go for. And, then, if need be, mammogram.
Okay, next slide, please. Yes, she did had a mammogram. Okay, and the mammogram, sorry, not mammogram, sorry, ultrasound. The right breast upper outer quadrant U3 lesion, uncertain, 25 millimeter, and also we noted some axillary node with the cortical thickness of 2.8. The question go to our radiologist, Dr. Vanitha Kapoor. So do you often see these kind of things, and what do you suspect in this patient, please?
Well, if I look at the lump radiologically on ultrasound, this is a hypoechoic mass which is irregular in outline, with non-circumscribed irregular mass with clefts within, central vascularity and peripheral vascularity. I would possibly give it a BI-RADS 4A category because of the shape of the lump and the appearance of the lump. And the cortical thickness of a 2.8 is not really significant because either it should be an irregular cortex or an effaced hilum or a cortical thickness more than 3 millimeters. So that is not what is bothering me, but the appearance of this lump is definitely bothering me. I would have, I'd just like to say here that because she's 39 years old, I would have possibly made her undergo a mammogram and then do an ultrasound breast because of her being a multipara, for her taking the oral contraceptives, and then done a mammogram and an ultrasound breast in that order and not vice versa.
Okay. Yes, like you said BI-RADS 4, it is more suspicious thing. And so, yes, as you said, the mammogram is kind of indicated in this lady. Yes, there are 2 schools of thought, less than 40, but 35 to 40 is the kind of a window where we, in some areas, we tend to do the mammogram straight away, even without seeing the suspicious lesion on the ultrasound, which we used to do in Western world, to be honest, like just a decade ago, everyone over 35 used to have the mammogram essentially. So that is what we used to do. Yes, she had a mammogram. Next picture, please. These are all hypothetical, okay? It is nothing to be related. So just putting it, this is the kind of scenario. What would you expect? Yes, please. Dr. Vanita, she had a mammogram as well. What do you think? Or any other investigation would you like?
Well, on the mammogram, of course, it is a dense breast, which is categorized as a bilateral. There's coarse bilateral calcification, which would be present in any sort of a benign breast disease as well. If I look at the right breast versus the left breast, there seems to be a diffuse increase in the density on the right side and in the upper outer quadrant versus the left breast. So I cannot see any microcalcification in this particular slide. Maybe I would have done a magnification view just to have a look if I suspected something. Otherwise, I would go in for an ultrasound guided core biopsy to get that mass before I undertake an MRI.
So you are thinking of an ultrasound guided core biopsy in this scenario. It looks like a mammo occult, whatever it is.
Yes.
If it were to be anything sinister pathology.
Yeah,
so you think it is a mammo occult, and then you want to do the ultrasound guided and then do the MRI.
Subsequently.
Would you agree with that, Navneet, or do you have any other views about it?
I think I wouldn't ask for an MRI at that stage. So MRI should only be reserved for shooting a problem. Right now we have a lump which is very well visible on a ultrasound. So we should go for a guided core needle biopsy. That probably will give us the answer.
Okay, right, fair enough. Iqbal, do you have any other thoughts?
No, I agree with everyone. Just proceed to biopsy and then go by biopsy. If biopsy show malignancy, will need an MRI scan. If biopsy proves a benign condition, then that we stop.
Okay, right. Next slide, please. Yes, she had a biopsy as well as MRI. Okay, as you suggested, because of the mammo occult, whatever it is, and it looks like, yes, suspicious. Between uncertain to BI-RADS 3 to 4. So she went for a MRI. This is what we found. Dr. Vanita, please.
You can see an enhancing mass, and you can see the mass is irregular again in contour and in appearance, but it seems to be confined in that area. So I just want to know what the ultrasound core biopsy said.
Yes, next please. Next slide, please. Yes, indeed, it was a lobular carcinoma that, which is not an uncommon thing, being a mammo occult, diffuse nodularity, diffuse fullness, and and also the size of the lesion is much more bigger. Yes, please.
The thing is that if you look at the mammogram itself, you can see a diffuse increase in the density in the whole of the upper outer quadrant.
Upper outer quadrant.
Side. So that is typical of lobular carcinomas. The importance in this case would have been to look at the contralateral breast on MRI, because as we've heard the previous speakers also saying, they tend to be bilateral or multifocal or multicentric.
Perfect. Thank you. So, as you can see in this scenario, it started with a benign nodularity, which possibly and turned out to be a cancer. Yes, common things comes first. We cannot forget this. Not necessarily every woman comes to our door is a malignant patient, but that has to be there in the back of your mind. Triple assessment is very necessary in these kind of patients to rule out any sinister pathology. Dr. Jyoti, would you think this pathway would have been happening in the clinic, or is there some other pathway you would go through as a gynecologist? Is it something which?
No, this is the right pathway. No, this is the right pathway. Every patient which come to our way, we always tell her to clinically assess her breast self-examination. We always tell her, but seeing the family history or seeing her personal history or seeing the medical history, we always tell her to go for the sonomammogram. And here the clear-cut lesion is seeing. So MRI and biopsy is the always we tell them to go for biopsy or FNAC or and then see to a CA, means the surgeon, breast surgeon, oncosurgeon.
Yeah.
This is the way the which gynecologist usually works.
Okay, perfect. That's what, like we hear same thing from the surgeons as well, which is a very nice thing to hear the same thing from both the parties. And now, we could have had some input from the pathologist about lobular cancer, but we have lost our pathologist. No worries. We all know that will be the next.
Sometimes patients come back to the gynecologist and asking her about the treatment aspects. The better way to say her, always better to say her to see her oncologist, oncophysician or oncosurgeon, because they are the better treatment giver for this particular disease.
Yes, that
Yes,
I think
Geeta, can I
is
say
very
something?
important. Yes, go on, Iqbal.
Yeah, just one thing. I mean, when I was training in India, and there's still a lot of radiologists and a lot of centers do FNA in for breast lesions. FNA should be used where you can't do the biopsies, core biopsies easily. For example, in high node in axilla where you have risk of injuring neurovascular bundle. So most centers, especially in Western countries, use core biopsy. Not most, all of them, and the FNA has become almost obsolete.
Agree with you. And I think we had extensive talk from Dr. Somshekhar, what to do, what not to do. So we are not going to ponder on that. So core biopsy should be the basic standard gold way of obtaining the biopsy. And yes, lymph node, I think it is discretion to the radiologist expertise whether they want to go with the core biopsy or FNA for the lymph nodes at least. Okay, yes, please.
Dr. Geeta, actually, we have to look at India as a big country. When we are talking about ultrasound-guided core biopsies, let's state facts that this is available in only tier 1 and maximum in early tier 2 cities. It is not available all over India. And we still have to do ultrasound-guided FNACs with a trained cytopathologist to get a diagnosis. Otherwise, the patient ends up with a poorly done excision biopsy. So just to say that this India is a country of contrast where we have very poor people and not so poor or better.
Yeah, I completely concur with your point, and we have to see what is available in the local resources, what is the expertise. That is what we need to see. But this is what this forum is, to take it forward, to train the people to do a simple core biopsy in a breast. Okay, this is what it is. And what's the significance of having the breast core biopsy rather than the FNA? So this is something which we need to take it forward. I completely agree. For the core biopsy, clinical core biopsy, you don't need ultrasound or anything. If they feel the lump, which is not plus minus, just put the needle and you get the tissue there. So it is not. Completely agree with you. So without further ado, we have to go to the next case because I already spent 15 minutes on this case. Okay, next scenario. 32-year-old woman with on and off redness and pain in the breast since 5 weeks. On and off redness. She also noticed some firm swelling in that area, in that local area. Local doctor, to whomever she went, you can call anybody, local doctor has given 2 courses of antibiotics, which hasn't seen any change in the symptoms. Now, her background is multipara, 2 children. She had the last child 2 years ago, now currently not breastfeeding. Some people, they do breastfeed until 5 years as well. So no family history of breast cancer. Okay, that is what you clinically see it. Bit of redness around the periareolar region, mostly in the upper inner aspect of the breast. And also there's a tiny area that looks little fluctuation. And whole of this feeling is more firm, vague swelling. Okay, so next slide, please. So that is what it is. Patchy areas of redness with fluctuation at one point, discharging some serosanguinity, not completely purulent, plus with associated vague firm lump. So what are we suspecting? So go to the, Jyoti, you want to start? And then we can go others.
Actually, her last labor is means 2 years old. Her last means her baby is. So first we have to see the any discharge. If means a thorough clinical assessment should be done, and if there is any discharge, seropurulent or milky discharge or red means blood stain discharge, we have to see this. And this fluctuating area, most probably there is a cold abscess, means the abscess sort of thing, infection. But you are saying there are 2 doses of antibiotic she has taken. So first we have to take only the history of infection and discharge, and then later on proceed. And I will suggest her sonography for particular this case, means total blood count and then sonography, and see for the medical history also. And then proceed after seeing the sonography.
Yeah, this is on and off, going on for 5 weeks. She had already antibiotics. She thought the local doctor thought it's breast infection. That's what they gave, but it is not coming down. But obviously there is an area of slight fluctuation with the serous C fluid coming up.
First I will go for the sonography and let us see what the sonography is saying. Then
okay. So what do you think, Navneet?
Yeah, as a surgeon, diagnosis is very clear to me. And I think for any investigation, we should have a clinical diagnosis first.
Yes.
Then only our report will make more sense to us. So with this kind of a presentation, it is inflammation of the breast or some kind of mastitis. And very classically, what you have described is fitting into that idiopathic granulomatous mastitis. So I would not rule out a possibility of another entity, which is ductal ectasia, periductal duct ectasia.
But actually, if it is duct ectasia, it will be subside by itself. Means not taking the
Madam, I
duct
think
ectasia.
duct ectasia can present with recurrent subareolar abscesses and infections. So that is one of the common presentations. And if there is a fluctuation and pus is there, we have to keep that possibility also in mind. So first diagnosis will be granulomatous idiopathic mastitis. And we should also maybe not completely rule out the possibility of a infective granulomatous mastitis. So inflammation is there. So diagnosis is mastitis first. And what is the etiology? We can have non-lactational mastitis or periductal ectasia or planocell mastitis, different names for the same entity, or it is an idiopathic granulomatous mastitis.
Okay.
So that would be the clinical, and then we will proceed with the investigations.
Okay. Right. Just hypothetically, you don't see any fluctuation or serosanguinous discharge. What are the other things comes to mind?
There are many kind of inflammations of the breast. There are some rare causes like actinomycosis. There can be vasculitis. There could be some foreign body reaction. So they are rarer causes, post-radiation mastitis. So these are rarer causes of inflammation. If we are looking at the most common, I think these are the differentials that come to the mind.
Okay, the inflammation of the breast, yes, rightly said, Navneet and Jyoti, is a kind of infection, and then it could be granulomatous mastitis. All right. Iqbal, do you have any other thoughts?
Yeah, and I agree with Dr. Kaur. Granulomatous mastitis will be my first diagnosis. I would like to know if she's smoker. The second differential would be periductal mastitis. One thing I've heard is in India, the duct ectasia and periductal mastitis are used synonymously, whereas here duct ectasia we use is benign condition, dilatation of ducts, not associated with infection. Periductal mastitis, the infection associated with the smoking affecting the central nipple areolar region. The third diagnosis, of course, malignancy, we have to keep in mind while investigating.
Yeah. Okay, just in one question, do you ever think of inflammatory breast cancer in this lady?
Sometimes.
And if so, if not, why? Any three surgeons, all three surgeons, in Jyoti, Navneet, and Iqbal?
Actually, unilateral, everything unilateral should be keep in the mind as a gynec perspective. If there is anything unilateral and more than 5 means after taking 2 shots of antibiotics and she is not feeling well, so one thinking of some possibility means always think for the worst also, not the best.
Okay, yeah, okay. So does that come to your mind, Navneet?
I would agree that never say never, right?
Yeah.
But in this scenario, since it is off and on, and inflammatory cancers won't regress just like that. So I would keep that 0.1% possibility.
Perfect. Yes. Okay. Next slide, please. So breast infection, granulomatous mastitis, the query, I would put it 3 triple queries for inflammatory breast cancer. We talked about all that thing. Then what are the investigations to order? Everybody came up with ultrasound of the breast is the first. So, okay, next thing, please. Yes, Dr. Vanita Kapoor.
So on the ultrasound of the breast, you can see edema of the superficial tissue and the subcutaneous area as well. There is an irregular hypoechoic mass with irregular hypoechoic mass. I don't see it continuous with a duct in this case. Sometimes we can actually trace it to a duct and then talk about that. But my first diagnosis would probably be, I'm not sure whether it is an abscess. It says I would try and aspirate it and see.
Okay.
Because it is obviously, to me, inflammatory in pathology.
Okay, perfect. So the clinical working diagnosis and the ultrasound pretty much fits together, because it is an ongoing, so you cannot rule out the other granulomatous mastitis and all, but it is an infection of the breast. Perfect. Is there any other investigation we would like to do in this case? I'll go to the surgeons first and then come to you, Dr. Kapoor, if that's okay. Okay. Jyoti, did you want to do anything? Sorry, I'm not addressing you.
Actually, if you are saying there is a
Jyoti
pocket of
is so easy for me to catch.
Actually, pocket of subcutaneous thick fluid you are saying, and it is unable to aspirate. The galactography should be done in this particular case.
Okay. Right. Anything, Navneet? Would you like to know more about this, which is not resolving with 2 courses of antibiotics? Do you want to rule out anything? Anything you want to do?
I think picture of ultrasound also is quite much in line with the clinical diagnosis of granulomatous mastitis. That is typically what it looks like. And I would definitely now like to put a needle. And just before the previous case, also the same debate of FNA versus core needle. I would say, and I would strongly kind of argue in favor of FNAC being the first tool. See, core needle biopsies one needle costs $3,000 in India. And the patients who are coming to public hospitals cannot think of spending that much of money, right? It is not in supply that we get. So FNAC remains the cheapest and immediately available tool to us. So I would definitely like to put a needle first and aspirate and see if I get clearly an abscess, infected fluid, then I don't have to think of a core. It could be still a subareolar abscess secondary to a perirectal mastitis. So that will, I think, resolve the expense on the part of the doctor and things can be managed. We can aspirate and cover with antibiotics which are appropriate. Maybe the previous antibiotics did not cover anaerobes, which are the common organisms for non-lactational. So maybe that is a cause patient is not resolving. So, and if FNA is inconclusive or gives a picture of, again, features suggestive of inflammatory granulomatous mastitis, then probably a core needle will be required before we think of putting on some treatment which are prone to side effects.
Yeah, okay, fair enough. And yeah, because you need a histopathological diagnosis of IgM here, perhaps the core needle biopsy if the FNA doesn't give anything for. So you, would you agree with that, Iqbal, or do you want to do anything else for her? Core needle biopsy, FNA, or anything else you want to do?
I mean, the simplest thing and what is going to give us the answer is the core needle biopsy, but ultrasound scan of the axilla could also help us if there are any pathological nodes point towards a malignancy, if not more towards the infection. And if on ultrasound, I'm only half expert in ultrasound, but if there is suspicion of malignancy, then mammogram could show some microcalcifications and help in diagnosis. But the bottom line is need a core biopsy.
Yeah, perfect. Okay, right. When you take the core biopsy, so what are the investigation it is coming to your mind? Can we go to the next slide, please? So we talked about what is the role of the biopsy. What would you contemplate when you do your contemplate biopsy, which Navneet has clearly explained. And the biopsy has shown granulomatous mastitis with acute on chronic inflammatory cells. I would have loved to hear from the pathologist about the cells and everything, but never mind. So what do we do further? if like, yes, management is, we will keep the management aside because the management goes along with all these investigations and everything. So what else do you do further? Shall I go to, is it Namriti is the best person? Yes, please.
Okay.
What
So
other
I think
investigation do you?
I would like to see the culture of the aspirate.
Mhm.
Just to pick up an atypical organism like Corynebacterium, we still don't know the etiology of mastitis,
Yes.
idiopathic granulomatous mastitis. So we
Yes.
have to rule out possible causes of infective etiology as well. So I would go for a smear testing and the culture of the aspirate and see if some organism can be isolated. Be it a normal commensal like Corynebacterium, or we may pick up tubercular bacilli. So all aspirates should have a acid fast staining as well, and a routine culture. And maybe that is one add-on thing that I would want at this stage.
Is that something you would contemplate, Dr. Jyoti?
No.
When you see these kind of patients, because the patients would probably come to you first. These are the something.
Most of the time, post-delivery or after having 2 years old son or baby,
Yeah.
I always think of the mastitis, but not the always thinking about the galactoria sort of things. So first, I always look after the discharge. What is the discharge? The discharge from the nipple, and doing the histopathology of the discharge, and then only proceed for the further treatment.
Fair enough. The nipple discharge, like that wasn't anything significant.
We are saying there is acute and chronic inflammatory cells are seeing in the biopsy.
Yeah.
So there is nothing to say about from my point of view. There is nothing.
Okay, thank you very much. So we did, like this is what the instructions, perhaps we need it clearly. I think probably Dr. Vanita will agree with me. Whenever you take a biopsy, please request them. Part of it goes to histology, part of it because another biopsy causes the money as well. You see, you just say that bit go to the microbiology, bit go to the pathology. Would you agree with that, Dr. Vanita Kapoor?
Absolutely. And the way Dr. Navneet has described it, I think I would just go along with that. And that will give me all the answers.
Perfect.
What we said is that supposing this didn't have anything, then obviously we would do a mammogram to rule out any microcalcification for an inflammatory carcinoma. But I would agree with this kind of thing as idiopathic or granulomatous mastitis.
Yeah. Perfect. So yes, the TB is still common in India, so we shouldn't forget that. The Corynebacteria, really, it is more academic. I don't know what we're going to treat with if we get that pathology as such, but at least TB is treatable. So if we have the opportunity when the patient is going for, this is a take-home message for our.
But in the tubercular patient, there is a lot of other symptoms also. So this particular patient is not showing any such symptoms or signs of TB.
Yeah, and then I agree with you. They may have a lymph node somewhere. They might have not been diagnosed. They might be showing it in the breast. Yes, if we explore it further and further, we will have some other symptoms in tuberculosis. But that will be a very florid tuberculosis. We're having the night sweats and everything. This is just a localized. So we have seen, trust me, even in this country, because the area where I live in, we got a lot of ethnic minority people. I was telling this in the last time. We do see pretty much typical of what you guys see there with the granulomatous mastitis. There is always 2 to 3 patients which are lurking in the clinic, which keeps going on and on, 2 months, 3 months, coming with on and off these kind of pictures. So always we rule out the tuberculosis as well. And out of 10, 1 to 2 people will have the AFB, and then they go to the respiratory medicine. It is not necessary they come with the florid symptoms initially. They may come with these kind of symptoms as well. I entirely agree. They should be looking for other symptoms. Okay, lovely. Next slide, please. So we shouldn't forget AFB, PCR, TB culture. How do we manage? I think I wouldn't go too much in it. Already Dr. Iqbal's talk has touched on it. How do we manage granulomatous mastitis? Unless our panel members has anything to say apart from what Iqbal, other than Dr. Iqbal's talk.
So
Would
I
you
think
want to? Yes.
Yeah, just in case those who did not hear the talk because sessions were delayed and somebody may have missed, so you can just complete that. We will give a short course of steroids, 6 weeks, 12 weeks. and response to prednisolone maybe start at a lower dose, 10 mg BD or 20 mg BD. And if the response is coming, well, we have to titrate the dose as per the patient's response. We should start with a smaller dose, but it has to be a course of 1 to 3 months. So some people would give it for 2 weeks and then stop because they think this is a drug which causes a lot of side effects. So if you have decided that patient needs a steroid therapy, you should be prepared for a longer duration of treatment, and also titrate the dose as per the patient's requirement, which can go pretty high also.
Okay, perfect. That is what it is. But always first treat with antibiotics, because steroids can increase, like if it is not the granular mastitis, what you're thinking, if it is because of the infective pathology, then that can flare up. So first treat with antibiotics, make sure the diagnosis is correct and it is not resolving with the conservative management, then go for steroids. That is what I have learned in my practice. But if there is anything different, please have a input, Navneet, you see. First, always treat with antibiotics.
Absolutely. Since you said this patient
then
received
make
2
sure
courses.
you got the right pathology to go on to the steroid.
Right.
Yeah. Perfect. Okay. Anything else? Anybody has any input in this scenario? Then we will go to the next, and where Dr. Gaurav is going to talk quite a bit then. Okay, next slide, please. Okay, here we got here 28-year-old woman with lumpiness in the upper outer quadrant, no discrete lump. Okay, so we know what is a discrete lump, what is the lumpiness now by Professor Sandeep Kumar. He explained what is the nodularity and everything. So 20-year-old woman with lumpiness in the upper outer quadrant of the left breast, noticed since 4 weeks. Okay, she came to you. She has come to you. No other symptoms. The background para 1, intermittent OCP. She's 28. She's still not thinking, like whether to become pregnant or not. So grandmother with the breast cancer at age 45. Mother is all right. She got another sister. She's all right. She's still breastfeeding 9 months old baby. That is the first pregnancy. Okay, right. Next slide, please. So what are we thinking is clinically prominent granular tissue in the upper outer quadrant, P1, P2, nothing else. So what are the working diagnoses? Dr. Jyoti, probably she will be coming to you of, I guess, these kind of patients, because she's still breastfeeding, isn't she? Yes.
Actually,
what do you think? How do you manage this case?
Actually, it is a painless lumpiness, and she is having a prominent glandular tissue. So most of the time I will, and seeing the family history, the diagnosis is not the benign. I don't think it is benign, though she is 28 years old. Glandular, I don't know. I think it is something. Yes, I will clinically evaluate her and do triple assessment for this particular patient.
Yeah, they clinically, just a simple
Because the patient is, it looks like a very simple clinical complaints, but seeing the family history at the age of 45 years only, grandmother, it is not that much simple. And breastfeeding and simple.
It was a grandmother, the first, agree. I know where you're coming from. And because her mother and sisters are okay. It's the grandmother who was diagnosed with a 45. The first degree relatives are okay. So
all the infective diagnoses are not in the mind, because she's not having pain, she's not having fever, she's not having any sort of discharge, and she is still breastfeeding. So the suspicion is towards the C only.
Okay.
And I will do triple assessment. And I will do the.
Fair enough. Triple assessment, that is something which we have to do. What do you think, Navneet, is going on?
Yeah, I think we have to take this campaign seriously, and definitely keep the higher risk of above average risk of malignancy in this particular patient because of the history that she has, a young age grandmother breast cancer. So triple assessment is the first step. And but still I would be very I would absolutely want to make sure there is no malignancy because of the history that she has.
Okay, yeah, fair enough. Okay, triple assessment we would come. Iqbal, what would you do if she were to appear in your clinic here?
Yeah, well, from what you told us, there's nothing for me to suspect anything apart from family history. So just proceed to the ultrasound and see what it shows.
Okay, right. If you don't have any ultrasound, what would you, how do you proceed in the remote areas? You know, not to you, Iqbal. I would go to Jyoti or Navneet. You know, did
Geeta,
you,
while you continue, I beg your pardon, I have to leave.
Okay, all right. Thank you.
Yeah, thank you everyone.
Thank
It was
you.
very nice. It was a lovely day. You know, I enjoyed a lot. So hope to see you soon.
Yeah, thank you. Thank you very much. Yeah, he was supposed to go at 1 o'clock only. Okay, right. If you don't have any ultrasound, do you reassure them to send her away, or do you still want to pursue with the thing?
Actually, any lump which occurs spontaneously without pain and unilateral, I will always go for the triple assessment.
You always pursue with the diagnosis, triple
I
assessment and
think I will if there is, we need to look at the patient couple of times more, not
Yeah.
after a long gap. So there may be some kind of a blocked duct which may be causing a local area of, so we have to think full spectrum of possibilities from a clogged duct and a gynaecocele to a malignancy.
Yeah.
So I think if in the periphery I'm not having easy access to a imaging investigation, I would ask the patient to report to me again after 1 week maybe and reassess the symptoms. If there is a persisting problem, then definitely there is no going away from the triple assessment.
Actually, every clogged duct or every such patients come with a lot of pain. If breastfeeding patient with the clogged duct, they come with a pain only.
So it is not a lot of pain, and they can be gynaecocele, which is not very painful. So these patients can have some discomfort, but beyond that, I think they will not be throbbing pain of a classical abscess.
Yeah, I agree. I agree with you know, Navneet. These patients, these are the patients who are breastfeeding. You always have one breast, a good breast, you know, where you get the milk more, and they always will be a bit more bigger than the other one. And you may find this lumpiness. Okay, you would ask, you know, like continue breastfeed, make sure you express the milk. Then I would have done, you know, come back to me in a week or 2 time. I'll reassess you. Probably I would have done the same thing. I must say, I wouldn't jump to the conclusion because common things comes first. Out of 10 women, maybe 1 patient, yes, it may be the case pathology, but most of the time it is a benign condition. I agree. So what happened next? Next slide, please. What happened was, okay, benign breast changes, you know, the common thing, common breast. So reassure and discharge. Okay, so that is what we happened in one of the community, and then she came back. Next slide, please. Next slide, please. Yeah, she came back. Unfortunately, she's 28. Okay, she came back with 3 months time with a discrete 3 centimeter hard lump in upper outer quadrant, which is quite aggressive. In 3 months time it has gone, and imaging and investigation revealed cancer. Okay, right, where do we stand here legally? Dr. Gaurav, it's all over to you. Thank you for your patience.
Thank you, Dr. Geeta, and thank you, Dr. Meenu, for inviting. So as far as the law here in India is concerned, first of all, we have to know at what time do we need to call the patient for a follow-up. Is it really 3 months or earlier? So if it is earlier and we're writing 3 months, that is a fault. And because of any fault of the doctor, if the patient suffers in damage, well, they see 4 elements that have to consider for before giving out the verdict of medical negligence. That is, first of all, there needs to be a duty of care by the doctor towards the patient. Secondly, that there was a breach in the duty or dereliction of duty. Thirdly, there was a direct causation of injury that the patient suffered because of an act of the doctor. And lastly, that there was some measurable damage caused to the patient because of the act of the doctor. So if the patient suffers because of that, and as in this case, she is being now diagnosed with cancer, which was not diagnosed earlier, the doctor has to show what all did she do to reach a particular diagnosis. For example, you ask, if you do not have an ultrasound, what do you do? So it is our duty to refer the patient. It's not, so our paperwork should be strong enough that we have done all that is necessary to reach a particular diagnosis. Because the patient cannot afford it, or because our circumstances are like that, that is not an excuse. Legally, our paperwork should be perfect For example, the patient is a beggar and she needs a MRI scan. We have to write it on paper that she needs a MRI scan. Otherwise, some NGO could catch hold of her and tomorrow put the doctor behind bars. That is the point. Secondly, an error in diagnosis is not medical negligence. For example, I'm just literally taking the subject here, but it is related very much to the issues that we understand that we encounter every other day. The patient is operated rather than going in for chemotherapy or radiotherapy. Or in the other case, the patient is put to radiotherapy and chemo before surgery. And this is one, preference of one treatment in relation to another is also not conducive to a diagnosis of medical negligence by courts of law. Secondly, if you were to make a diagnosis of benign disease vis-a-vis carcinoma, if the patient does not, patient is not suffering because of that. See, if the patient has cancer, she's going to suffer. But if the diagnosis you made was benign and the patient has suffered, it would definitely go into the direction of medical negligence by courts of law. But on the other hand, if you label it as carcinoma and the patient was benign, patient still may go to a court of law. But in such a case, we have many cases that the courts have said that the patient has not suffered any damage except maybe a little bit of mental harassment. So that would not be a medical negligence. That is one way of looking at it. And there have been cases where, gynecologists have published papers that, in my opinion, or in the research that I have conducted, I would preferentially go for surgery as the first mode of treatment in a diagnosed CA breast in comparison to radiotherapy or chemotherapy. But in that particular case, which went to the court, she opted for radio plus chemo in preference to surgery. Courts have also come out in support of the doctor, saying that it does not matter what she felt in part of the research that she's done. It is all right that in that particular case, she preferred for non-surgical treatment. So it is all right. If you can prove at that point of time, at that point of time in the society, both were acceptable methods of treatment, and there are pros and cons of both, and that in preference to another, you preferred one mode of treatment. So there were some topics I wanted to touch. Maybe you have, if you have more questions, we'll go ahead.
Okay, thank you. What I can see here is documentation. Documentation, because we need to go back and see what the doctor has said and what the doctor has written in the notes. The documentation is utmost important. To all the participants, I'm saying, especially the young generation, those days are gone when you used to write something on the notes. No, documentation is very important. Whatever you think, whatever you write, that's something which I can hear from Dr. Gaurav. Although patient opt for something else, then it is her choice. But what you recommended has to come in the paper. That is what I can hear. Okay, what you recommended. Is there anything else to add from you?
Dr. Geeta, if I can make a point here, Dr. Meenu.
Yes, please. Yes, please. Yes, please.
And I think Dr. Gaurav made a very, very valid point, because in our own clinical practice, I know what happened with one of my colleagues only. So a lady was seen in the OPD and a working diagnosis of carcinoma breast was made, and plus a few investigations were asked for. So after a week of investigations, finally the lady did not turn out to be malignancy. It was a benign lesion. And later on, she went to the, although very unlikely, we do not see that very commonly, but she did go to the court and then had asked that he had to go through mental harassment for 1 week because she was labeled as carcinoma breast and then carcinoma breast. So this is a real case from our own experience. So what I just wanted to point out is they are both sides of the coin. So I think unless proven, we should always be putting a query carcinoma breast or a suspected carcinoma breast. That will save us in these cases also.
Yeah, I'll just add a little point. I had a similar case. My client was a doctor who had labeled it as carcinoma and later it turned out to be benign. It happened at Maulana Azad Medical College. Premier Institute, where we are from. So, I'll just add one thing. If we are in a very bad habit, I would say, of putting a query before the diagnosis. Query CA breast, query benign lesion of the breast. Now, this is a graveyard as far as courts of law are concerned. Why? A query can have many meanings. The court, what does the court think? Sir, how does the court look at it? The court looks at it, the doctor is not sure. Doctor does not know his subject. Doctor is not sure of what to write, what not to write. The better way of writing it is you write a differential diagnosis right then and there instead of the query. Differential diagnosis, benign disease of the breast, comma, number, that is one. Number two, CA of the breast. That would be a better way rather than putting a query. We all, irrespective of specialty, whether radiologists, pathologists, oncologists, physicians, gynecologists, we all write query this, query that. This is a graveyard, let me tell you. And let us write 2 or 3 differential diagnoses, 1, 2, 3. Just write DD. That would make more sense legally as well as, medically speaking, I would say.
I think very interesting point. That is the learning.
Yeah, that is a take-home message, guys. Like the documentation, differential. See, we are not God here, okay? We have to pursue with further investigation to know what it is. So there's no harm in having few differential diagnoses, suspected diagnosis here, okay? So be clear on your documentation. So put the differential diagnosis, further investigation needed. Then reach out for the further investigation in the order. And it is up to the patient. I know, I can understand if some people can afford, some people will be overdiagnosed or something. So, but it is up to the patient. But that would be your approach to that problem of the patient.
Overdiagnosis is always better. Better to miss the patient of CA. Better to do overdiagnosis always.
Yeah, to partly I agree, Dr. Jyoti, but common things we have to keep in mind. And also, I feel that we should not overtly make patient worrying. As you rightly said, Dr. Gaurav, that the patient, and also Dr. Meenuwalia. So because that patient must have had 1 week of mental trauma of the patient with the query carcinoma for whole 1 week, but there's a reason why she went to the court there, okay? So we have to say the likelihood of benign diagnosis is more than the cancer. But however, we cannot rule out, we need further investigation. I think the wording is very important when we talk to the patient. That is where we come to the counseling, how we talk to the patient and how we deal with the missed cancer, the second aspect of this talk. I think we can spend a few more minutes and then we can conclude. So how do we counsel those kind of patients? Shall we go to Navneet and then we will take it from there? What would you say, Navneet, in your clinic, if you find these kind of patient, how do you counsel them? First thing.
I think first thing is how to break the diagnosis to the patient, right? And half the time I ask the patient, do you want to know what is the report like? Because many patients will say, no, we don't want to know. So then I don't insist that they know the diagnosis, but if the family members tells me that please don't talk in front of her and you ask her to go out and speak to me indirectly, because this is what some people are overprotective. They think they are doing a very good job by not letting the patient know what the illness is. And half the time I see patients are also not ready to get that news, right? Even in their heart, they know they have a malignancy, but they are not ready to take that diagnosis at that point of time. So I give them time. So I say, if you are okay, there are some tests and we are, so I don't abruptly give the news. And and I always keep saying when the patient is to be given, when they come, they want to ask, they want to know it's malignancy or not. I say, till the time I have the reports, I cannot tell you for sure what it is, but I may suspect this or that. So I keep that scope of changing the diagnosis later rather than giving the diagnosis provisional on day 1 as the malignancy. And also see whether the patient is in a mental frame of mind to take the diagnosis. If not, then I tell the attendant first, they can talk to the patient, they can come again. So one thing is, without being sure, don't give a diagnosis of malignancy till the time you have the reports, and then see whether the patient is in a position to take the diagnosis when it is ready, or give them more time, indirectly convey. some people would want to know, and I feel that patients should know what their diagnosis is, unless they themselves kind of are scared. So that is probably how I approach.
I agree that because in India, the setting is very different than here, because we first have to talk to the patient here, which is very different. So I completely agree. What is best at your local thing? But I think it is the patient has a right to say something, that whether I don't want to know more, you can talk to my family members. That means she's giving an advance directive to the family members to, about her health, to take the decisions, which is fine. It is her choice. Okay. But I think we need to ask the patient what Dr. Navneet Kaur rightly said. Ask the patients whether you want to know more, or you want me to talk to your family members, which family members, son, husband, whatever it is, daughter-in-law, whoever it is, daughter, just clarify that and make a note, document that, make sure that the patient does not want to know more. So hence the family members are involved in this patient care. I think that will solve all the problems.
Most of the time we say the patient, if patient is agree to listen everything, we say patient to reconfirm the diagnosis from the other center. If she is willing to go for the other biopsy, go for biopsy again, and she is in affording class, we always say, if you want to reconsider, if you want to reconfirm the diagnosis from the other centers or other doctors, shall I give you the list of the doctors, or you go by yourself also? I always give them liberty to go to other doctors also.
I think you made a right point, Dr. Jyoti, because in the era of so many shopping around, they go and keep shopping around, like it happens. I've seen it as well. Even here as well, don't get me wrong, they want a second opinion from different surgeons or anything. So it is always have that open mind, saying that if you are not convinced with what we are trying to treat you and what we are trying to say you're more than welcome to go to the other centers and take their opinion as well. That is something which the newcomers have to understand. Those days are gone. You have to keep the patients to yourself and then do the things. No, you will be in graveyard if you think like that. Always have that open mind, give that option to the patient. Then you will in fact gain more trust by giving that option. That means that you don't have anything to hide what you've done so far. So I think that is very important, especially in the Indian setting, in the era of so many things happening over there. I completely agree. One more last thing I'm going to ask and then close this session, already overrun by so many minutes. Right, if you missed the diagnosis, how would you approach? I'll ask 1 minute from Jyoti, 1 minute from Navneet. Quickly, and also Dr. Gaurav to collectively tell me the outcome. Okay, Jyoti, if you missed the cancer, okay, the patient, by chance it has just gone and then came back with the cancer. So she's asking you even before suing or going anything. How do you approach the patient?
Actually, I'm working in the charitable trust and seeing 150 to 200 patients per day. There are most of the time there are chances to miss such patients. Most of the time I do my writing work perfectly. And what I am telling to the patients, I always tell them to report me in the every third or fourth day, whether I am overworked or not. Even my assistant is seeing. But by chance, if I missed and the patient with the relatives comes to me again, then I accept my fault. So not guiding them well. I accept, and I always give them the percentage of a patient, means I gave them percentage that only 17% of the patient of with such carcinoma, and most of the time the gynec or the surgeon misses the diagnosis. I always try to convey that this is the common happening with the gynecologist to miss such patients. And if they are not conveyed, I always opine with the senior oncosurgeon or senior gynecologist and take them in my faith, and whatever possible for me to guide them for the better oncosurgeon. And I always stand there for the FNSC or the operating procedure. Most of the time I stand them with the patient only.
Thank you, Dr. Jyoti. You made
in return, I apologize the patient that I missed that.
Correct. So I think that is very important point which you have made, and then I don't want to go and summarize the same thing. Navneet, have you done anything different, or what would you have any extra input?
Okay, I think I can say many things about it, but in the interest of time, just a couple of points, right? So fortunately, nobody has ever come back and accused me of missing the diagnosis, which was very evident. At times, there may be like some tests. I tell them whenever we are doing a diagnosis, we are taking a test, and that test has a certain sensitivity and specificity. Not every test is going to be 100% accurate. So it is quite possible that on FNA and even core needle biopsy, the lesion was missed, and then patient has come back with a more clear-cut lump, dominant lump, and then this time the diagnosis is confirmed. So it is not that the approach was wrong, but that every test has a limitation, and so a very early lesion may be missed, and inappropriate reporting may be the reason the lesion was missed. So probably I would like to look into the reason why it happened, which will not happen because there's a lack of clinical judgment. And I work in a government hospital where there are 400, 500 patients in OPD. And they are the ones who are just grateful that you are having a consultation with them. Nobody will ever come back and complain like that. But if they pay and if you have half an hour with them, then you have to be absolutely methodological. You can't afford to miss.
Here is the major role of counseling only.
Yeah.
I agree. Dr. Gaurav Agarwal, what would you say? How
So legally speaking, I would say, Okay. So legally speaking, this Dr. Jyoti, it would be a huge error on one's part to, apologize in writing. It's
So
like,
I always write, I have guided them to come after 3 days, but patient turned out after 3 months. And at the time limit of the 3 months, this happens. So I write everything in black and white on my
documentation.
paper.
That
Documentation
is
is there.
and
then
Fair enough.
Yes, Dr. Agarwal.
But yeah, if I were to apologize, it should be verbally rather than writing, because the patient will take me to court tomorrow that it is because of doctor's fault that I suffered. This is one aspect. But, if I were to, one could miss a diagnosis, a lump maybe clinically, and one could miss it radiologically, histopathologically. And the third level could be by a, super specialist, oncologist, oncosurgeon. So as far as physician is concerned, the responsibility lies whether he, prescribed enough investigations to reach out to a conclusion as to diagnosis. So he's safe that way if he misses out on a lesion. Now comes the part of radiologist or pathologist, investigative services. If a radiologist can, justify, probably there was a shadow of an adjacent organ or a structure that that limited the scanning of that particular lesion that was trying to be, scanned. Similarly, a histopathologist, if they can justify that there could be a differential diagnosis, they should never write, okay, it is, unless they are 100% sure, maybe you've done histochemistry or whatever for the investigations are needed to conclude the diagnosis 100%. If there is an iota of doubt, you always write differential diagnosis. That is the safest part. Coming to the, a super specialist, if they may miss out, despite what they give wrong treatment or some treatment. Let us say a famous case that happened in AIIMS, New Delhi, was that the patient had a benign disease, and it was, wrongly diagnosed as CA-breast, and the patient had undergone mastectomy and even radiotherapy. So for that, AIIMS, being a government hospital, had to shell out 5 lakhs rupees of compensation, and that was almost 12 years ago. So for today's amount, that could be anywhere around 20-30 lakh rupees, and that too from the pocket of a government hospital doctor. So medical negligence, of course, it can be there if you are, despite knowing fully well and not confirming the diagnosis from, the AIIMS, they ignored the report of a benign lesion of histopathology from outside. They said, we'll do our own. And till the time their own report came, they had already performed a mastectomy. So that was a huge, or what we legally call as gross negligence. So we have to, take care of this, that unless we are 100% sure of the diagnosis, we should not move ahead. And the lesions would not be, just to make sure that if there could be chance of missing out on a lesion, we have done enough to make sure that it could be discovered. If not now, maybe later on at whatever date.
It's better to do stepwise assessment and always write. If patient is refusing for some particular test or particular visit, so always better to write on our paper. The patient not came or patient refused for this investigation or something.
Yeah.
So we
I
have
agree.
to get into a habit of writing everything negative about the patient's history. We often miss out on this. The patient cannot afford. We don't write enough things about it. Patient reporting late, we don't mention it in the papers. Patient not taking our treatment, taking some Ayurvedic, homeopathic or Jadi-Buti treatment, we don't write it. We have to write every damn thing the patient is taking on the paper. Now that goes in our favor tomorrow in the court of law.
Agree. So documentation, documentation, documentation. That's what I can hear from Dr. Gaurav Agarwal now. Right. I think we have already run out of a lot of time. I will leave it to the chairperson to summarize and then conclude the session. And thank you very much for allowing me to do these sessions. I hope you all had a nice time. Okay.
Thank you.
Thank you. Thank you.
Thank you. Thank you.
Jayam,
Is the chairpersons are there around?
Jayam, madam?
Dr. Jayam Kannan and Dr. Jaideep Tank. They must have gone, because we were going on and on and on, I guess. Right. Okay. I think I'll conclude the session anyway. So thank you very much. So what we all can see that different documentation of differential diagnosis, detailed letters to the patient. Don't ignore that. Don't ignore that anything that because the patient is poor, patient is cannot afford, that you can't do. They cannot afford, so that there's no need for further anything documentation. Please do not do that, because anytime the things can come and bite you. So those are the things what you can conclude from this session, and never ever say that this has been ruled out. Always, common things are common, but always have a differential diagnosis. Like, even though there's a benign breast disease is there at the top of the list of the diagnosis, cancer shouldn't come out from your list at all. So that is, I would conclude from this session. The communication issues, we can go on for whole of the session, but we have done as much as we can here. And thank you for our panel members. Thank you very much, Dr. Jyoti, Navneet.
Thank you, Navneet and Dr. Gaurav. Thank you very much, everyone. Thank you. Thank you, Shruti. Thank you, Shruti, for making us part. Thank you.
Yeah. Shruti, are you there?
Thank you, Dr. Geeta, for a wonderful panel discussion. You were awesome. Yes, Dr. Tank had to go, but the learnings that we had from the session, they were very nice, and especially the takeaways with Dr. Gaurav and the radiologist, Dr. Navneet, they were wonderful. And thank you again for bringing out these impressionable points, which all gynecologists need to know. Thank you so much.
Thank you. Thank you for having me. Thank you.
Shruti?
Yeah, ma'am, I'm so sorry. I'm back. I had lost network for some time. But it was a terrific panel discussion. I think I enjoyed it being a non-medical, but I thoroughly enjoyed this panel discussion. A lot of new insights, a lot of new learning. And so I think with this, we should quickly move ahead with the quiz. I think a lot of people have been waiting for this. So over to Meenu, ma'am, so that we can start the quiz.
Since we are already running late, so we would like to keep it as short and simple as possible. We have decreased the number of quiz questions also. So a link has already been shared in the chat box. Participants, please, you need to open the given link. Fill in your email. Your name should come first. Your response will be recorded along with your name. That is why we want your name also. And then you start answering the questions. You will be given a total of 5 minutes to answer 10 questions, 30 seconds each question. And these are in multiple choice forms. Just tick the right answer. And once you are done, do not forget to submit your response. So unless it is submitted, it is not captured. And yes, the decision of ours is going to be the final. And the person who has the maximum correct answers and in the least time, because the Google will also record the time, how much time was required for you to answer the question, shall be the winner. And in case of a tie, a lucky draw will be performed and results will be declared on ICanCaRe Facebook community page. So without wasting much time, I think we go to the quiz directly. And I guess everybody would have, the link has been shared and people would have downloaded the link and entered their names also. So question number 1 is, so this is a celebrity. I think everybody in today's generation will know about it. So this celebrity, yes, apart from being linked to Hollywood, she's also linked with something else. So option A, breast cancer. Option B, endometrial cancer. Option C, HPV vaccine. And option D, prophylactic mastectomy. So remember, you have to take the answer which is most closer, which is the closest answer that is to be ticked. Question number 2, a blood-stained nipple discharge. We heard a lot about it today. Option A, breast abscess. Option B, fibroadenoma. C, a ductal papilloma. D, fat necrosis of breast. Question number 3, a 40-year-old male patient. 40-year-old male has a painless lump in his chest. Physical examination shows an induration, retraction of the nipple and a mass in the nipple well. This lump is fixed and non-tender. What is your most likely diagnosis? So this is a male patient with a lump in the chest wall with nipple retraction and induration. So is it a chest wall abscess? A. B is acute mastitis. C is gynecomastia. And D is breast cancer. Question number 4. Female patient, single, irregular, non-tender mass in the breast. She has a positive Montague's test and a chest radiography which is suspicious. The most likely, the answer is the most likely diagnosis is fat necrosis, breast abscess, tuberculosis, or breast cancer. Question 5, fibroadenomas are most frequent in women between the age of A, 15 to 39 years of age, 20 to 30 years of age, 35 to 55 years of age, or 40 to 77 years of age. Unilateral breast discharge. Question number 6. Unilateral breast discharge is usually associated with all except intraductal papilloma, B, breast cancer, C, pituitary adenoma, D, ductal ectasia. Question number 7. 55 years old female patient has a lump in her breast. The lump is hard, non-tender, fixed. Irregular borders, not well defined. She also has some associated nipple discharge. Most likely diagnosis, working diagnosis, mastitis or breast abscess, fibrocystic breast disease, breast cancer, or a fat necrosis. Question number 8, a breast mass with bloody nipple discharge may be a symptom of Paget's disease, A, B, fat necrosis, C, a ruptured implant, D, breast cysts. Question number 9, young teenager, 16-year-old girl with a sharply circumscribed mobile lump, single lump in the breast. Most likely diagnosis, A, fat necrosis, B, breast cyst, C, breast cancer, D, fibroadenoma. And this is the last question again, so that we wind off. There's again a celebrity in the picture, and she is a cancer survivor. So she is a cancer survivor. Which cancer? A, breast cancer, B, ovarian cancer, C, cervical cancer, and D, multiple myeloma. So that's it. We come to the end of the quiz. And over to you, Shruti.
Thank you so much, ma'am. I think it was really wonderful. We had a great session today because I thoroughly enjoyed, being a non-medical, thoroughly enjoyed the sessions, understanding, learning so many things.
Shruti, you are not audible.
Not audible? Is my voice audible now? Am I audible now? Is it better? Better, ma'am? Can you hear me?
We can hear you.
Okay.
Hello.
Yeah.
Now you can, no? Okay.
Yes.
Okay, perfect. Perfect. I would like to thank everyone, all our audience, lovely audience who had been very patient for this 4 hours, the 3 hours program. I think it was terrific. Just prolific panel discussion and extraordinary scientific sessions with so much of learning involved for so many things and great takeaway messages, especially for the triple assessment. I mean, that's a great takeaway thing, which is mentioned by Dr. Somshekhar and all the faculty who are here with us. So we're going to meet up next Saturday again at the same time with yet another important discussion on malignant breast diseases. Today we had a session on benign ones. So we're going to learn more on malignant diseases. So stay tuned. And I would like to invite all of you to be a part of this E-Conclave, the International E-Conclave, again on next Saturday at the same time. Thank you so much, everyone. Have a great weekend ahead. Have a great night ahead and enjoy the weekend thoroughly. Thank you so much. If anybody has any questions, please feel free to post it on Facebook. ICanCaRe Facebook page, and we would be happy to answer all those questions. Thank you so much. Have a great day, everyone.